bounce back webinar, coexist with COVID, options versus choices. We are most privileged to have with us a panel which includes none other than the President of the Indian Orthopedic Association, Dr. R.C. Meena, the President of the Maharashtra Orthopedic Association and Organizing Chairman of Ioacon 2020, Dr. Ajit Shinde, the man who comes from the premier institute in New Delhi, All India Institute of Medical Sciences, to whom everybody is looking at because they take the initiative and the rest of the country normally follows, Dr. Vivek Trika, Senior Orthopedic Surgeon, Dr. Sushrut Babulkar, the man from Nagpur, who was responsible in many ways on the 1st of May to create the MOA guidelines, which then were also added to the IOA guidelines and were presented on the 5th of May by the IOA through Dr. B. Shiv Shankar, a very senior orthopedic surgeon from Nagpur, Dr. Chetan Pradhan, who was equally responsible for those guidelines and who works at the Sancheti Hospital in Pune as a leading trauma surgeon and who is still struggling between emergency, semi-emergency and elective. We have also with us Dr. Ashish Fadnis, trauma surgeon from Mumbai, Thane, Jupiter Hospital, presently a member of the executive committee of the Bombay Orthopedic Society. We have Ashok Sham, the man who makes all these things happen. He's an excellent orthopedic surgeon and a brilliant thinker who helps us with all the guidelines. And above all, we have the lady who has all the brains and who's going to control both the hands and the hearts of the men here, Dr. Amita Nene, pulmonologist, chest physician, Bombay Hospital, Mumbai, who has helped us in more ways than one in thinking about the disease COVID and not just about the fracture femur. Thank you very much for all being here. And without much ado, on behalf of Dr. Vishal Kundani and myself, the two of us who are going to be moderating this session, we would like to invite the President of the Indian Orthopedic Association, Dr. R.C. Meena, to set the ball rolling and show us the way forward from May 21st, 2020. Meena Sarji, please.
Thank you, sir. Thank you, Ram. So, good evening, everybody, those who are connecting this webinar today, and greeting from the Aya House and all best wishes for during this crisis COVID-19. On the behalf of IOA, I welcome all the participants in this webinar series organized by the Ioacon 2020 organizing team in collaboration with the IOA. I am damn happy to see this kind of program which has been started nicely by the Ioacon 2020 organizing team. He is doing a wonderful work for this cause, and this association in between the Ioacon organizing committee and IOA, I am sure will do the more beneficial and wonderful work for the Orthopedic Association and the surgeons across the country. In this uncertain time of corona pandemic, who is have cancellation of almost all physical conferences and lockdown have forced us all to stay inside the house and postpones our routine OPD, ward work, indoor work, operation theaters, and day-to-day home practice as well. This webinar series will help our orthopedic surgeons keeping updated with knowledge and with them engaged with the academics. And with the Dr. Shinde, Dr. Ramchandra, Dr. Vishal, Dr. Amit, Dr. Chetan, Dr. Susrat, I'm damn happy to see that this webinar will be a grand success, and the many legends and veterans from the IOA who are off the screen or side the screen definitely will join this webinar and make a grand success this webinar. Team has put together an excellent academic program for this webinar. This shall be beneficial to all the orthopedic surgeons and definitely increase their trade and will apply them with the recent trends. My vision for the year is seeking the perfectionism and excellence in the orthopedic education and patient care, which has been put on hold temporarily due to this pandemic. And this webinar, in collaboration with the Ioacon organizing team and the IOA, will definitely take my vision forward. For this, IOA has laid down the guideline how to protect yourself, how to protect your patient and your family of 71 pages that has been put on the website of the IOA. And Doctor, I am really thankful to my whole team, my President-elect, Dr. Shiv Shankar, Dr. Ramesh Sen, Dynamic Secretary Atul Srivastav, and our more hard laborious worker, Dr. Manish Dhawan and Dr. Sandeep Kumar, with Dr. Anil Arora, who have done a lot of work to finalize and formulated all these guidelines to put forward all of you. And now it is for you to discuss this, that how we can utilize this, how we can promote these the guidelines. And here I do not think to describe and give much introduction about the COVID-19, as you daily see in the newspaper and in the media and the social talks like that. So I wish them all the best, my friends, and keep stay in the home, keep maintain the distancing and the sanitization of your hand, and follow the protocol and guideline by the IO. Jai Hind, Jai IO.
Thank you, Dr. R.C. Meena. It has been really so kind of you to spare some time for us and welcome all the delegates and participants here. Needless to say that we have as many protocols and guidelines available, enough to confuse us for this whole lifetime. Forget about this decade to come where we will be living with Corona, and then we'll be trying to coexist and find our relevance again. May I welcome Dr. Ajit Shinde, the President, Maharashtra Orthopedic Association, to please address all the delegates and let us know about MOA guidelines in brief. Dr. Ajit Shinde, please.
Good evening, dear friends. Welcome back to the Bounce Back series, 6th episode. I, Dr. Ajit Shinde, President of Maharashtra Orthopedic Association and Organizing Chairman of Ioacon 2020, wish you all safe and healthy life in this unprecedented COVID crisis. I am very delighted today as my organizing team has chosen COVID protocol as the topic for the discussion, which has affected every individual, every aspect of life and human existence. We have been pledged to serve the society, and while doing so, we need to know how to protect ourselves while treating our patients. On behalf of MOA, I would like to thank IOA President Dr. R.C. Meena Sir, Secretary Dr. Atul Srivastav, and all dignitaries for providing personal protection kit in the form of mask and face shield to the all IOA members. We have received it and we have distributed it in our Sangli district. Now, considering exponential rise in the COVID crisis in our country, I believe that actual number of cases is much higher because many of cases remain unnoticed due to lack of testing facilities, and in our daily practice we may come across such asymptomatic carriers Because of this, I am still in dilemma regarding choosing the right patient and right treatment modality to be safe on either side. Actually, we had a webinar on MOA Day, 1st May, where Dr. Shushruth Babulkar and Dr. Chetan Pradhan has given the guidelines. So it is very essential to form a protocol for OPD, IPD practice as well as precaution to be taken in the operating rooms ward to avoid the mishaps. To discuss these issues, we are having brilliant panel of Dr. Ram, Dr. Vishal Kundnani, Dr. Tika, Dr. Ashok Sham, Madam Nene. So without wasting much time, let's hear what this expert has to say. Over to Ram, Vishal and Sham. Thank you.
Thank you.
Thank you, Dr. Ajit
very
Shinde,
much,
for
Dr.
bringing out-
Shinde.
Yeah. Dr. Ram, may we have the overview from you, please?
Thank you, Dr. Shinde, for telling us कि राम और श्याम विशाल काम कर रहे हैं. Thank you very much, sir. We appreciate the way you ended the whole thing. Thank you so much. And
Ram, at
without
the end,
much
I would
ado,
like,
with,
Ram, can I say a few words? Ram?
yes, sir,
Are you-
please.
Yeah, yes. In the last, I have forgotten to give a special thanks for your wonderful organization for this webinar, Dr. Vishal, Sinde sir, and Ashok Shyam as well. Really, you are doing a wonderful job here.
Thank you, sir.
Carry on.
Thank you so much,
Carry
sir.
on. Carry on.
Thank you, sir. We understand, Dr. Meena, that you may have to leave in some time because you have a lot of commitments. But thank you very much. Please stay as long as you can. Please come
sir.
back whenever you can, sir.
Till
Okay.
the phone will not
So,
come there, I
I
will.
will-
Sir.
Okay. Thank you, sir. Thank you. Sir. So, without much ado, I would like to share with you a short presentation to set the ball rolling. We have reached a stage today where we don't have to fight COVID, but we have to make peace with COVID and coexist with COVID. We have reached a stage where we have options which COVID have given us, and the choice left to us. Options are like the cards which are given to you in a game. Choices are the way that you play those cards. On 5th of May, we had 46,000 patients. And that was the day the Ioacon guidelines came out. On the 15th of May, we had 81,000 patients. And that was the day that the Ioacon guidelines were openly announced. And I was given the privilege to share it with everybody. Today, we are in a situation where we are beyond 110,000 and about 3,500 deaths. Maharashtra is touching about 40,000 confirmed cases soon, and Mumbai is touching 25,000 confirmed cases. Do I, as an orthopedic surgeon, need to modify my practice? Yes, I do. It was an ophthalmologist who in the last week of December found a few of his patients in China, Wuhan, who looked different and had a SARS type of a picture and felt that the disease was happening and shared it with this country. However, the Twitter handle there, the so-called Twitter handle there, shut him off, and unfortunately this ophthalmologist became a COVID warrior on the 7th of February. Dr. Li Wenliang, like many of us, tried to warn the world, but could not implement it for himself. We are living in a country where we are looking at healthcare of the country. We are looking at minimizing healthcare resources. We are trying to prevent the spread by social distancing and contamination. We are looking at a situation where there are guidelines which do not give us a direction. And we are also looking at situations where our prophecies scare us to the extent where people are talking of 10 times to 100 the times of patients that we are supposedly seeing. We have new habits which have become a part of us, which include namaste, wearing masks, washing hands regularly, avoiding spitting. We have everything which we are aping from the East and not the West anymore, which is how to curtail us from spitting, how to wash our hands and sanitize, how to keep
very soon, Dr. Ram will join us in a while. The overview is we have plenty of questions right from the day COVID came into picture. It was way back in April when we did our first webinar on co-orthopedics, which is orthopedics along with COVID, and how the world will evolve. And that was then when we said that the world is now only going to be divided into 3 phases of life: before Corona, with Corona, and after Corona. Unfortunately, the after Corona phase is long to be seen. Until that time, this phase of unending with Corona times is going to be there. We had multiple questions to which we never had answers in April. Today, we have multiple answers and few questions to which we will probably, as evolve, find answers. The need of evolving into practice has been overemphasized time and again. We know it very, very clearly now. Dr. Ajit Shinde emphasized that we are going to be seeing more and more asymptomatic patients walking into our clinic. And that's why we need to be really ready to deal with these asymptomatic patients who will really not be looking like your enemies. And on one hand, you will be practicing your orthopedics. On the other hand, you'll be stranded and would want to deal with these asymptomatic patients, not only protecting yourself, your interests, keeping staff safety in mind, and the paramount thing, delivering the same kind of healthcare that you used to while protecting the patient's overall health concerns. COVID is only 6 months old, but it's probably going to see next 6 years with us. 1.5 million cases were there only on the 12th April, and numbers were only growing at that time. Today, there is a mixed news. On one hand, Government of India has already shown the way that lockdown is no more going to be there by the 31st of May. Airlines have started. That's a good thing to happen. Unfortunately, today, world has seen 50 lakh cases already done. Today, 5 million patients are suffering from COVID, 1.25 lakhs of them in India. And mind you, the numbers will be 30% more given the false negative rate of the diagnostic testing available. 3.5 lakh people are dead already, 5,000 in India. And mind you, India is yet to see the peak in coming 10 days. Despite all this, we all know lockdown is never going to be like an infinite mode. Lockdown is going to be over, but Corona is here to stay. And that's why you got to embrace yourself. You got to embrace good practices. You got to start looking at these protocols that have been made. And today, this webinar is all about how to follow these protocols, learn from all the protocols that have been laid down, and how to bring all these points to ponder in our practice, keeping safety as paramount both for doctors and healthcare workers and also for patients. Today, we have too many answers, unfortunately. It's an infodemic of protocols, but little is known how to implement them. Like Dr. Trikha just emphasized, we already know about protocols. They have been started writing from 1st of April, and today there is a wide array of protocols. But how to apply them in practice is what we are going to discuss today. And today we have a wide eminent faculty. So let me just invite all my panelists here. Dr. Ajit Shinde, Dr. Chetan Pradhan, Dr. Shushruth Babulkar, Dr. Vivek Trikha, and none other than Dr. Amita Nene. May I ask you upon your opening comments on this? Are we really ready to take up this war forward with elective work, or we still continue doing only emergency work from here? Are we really geared up? Are we already having all the armamentarium protocols ready to start elective work, or we should still hold upon? Dr. Amita Nene, your opening comments on that, please.
So actually, if we are talking about Mumbai, then I kind of feel that elective work is absolutely, you cannot be doing it till the lockdown is there. Mumbai is actually expected to peak in 10 days. We already have such horrible numbers. Once we peak, next 4 weeks are really going to be very, very bad. So for Mumbai, I'm actually saying that no elective work, please. Absolutely not.
Dr. Amita, we also have a lot of like 20,000 plus orthopedicians sitting in their clinics, which is itching them. And in fact, there are plenty of doctors who have already started doing elective work. Any suggestions for them, and how is the way forward from here?
Yeah, so actually the thing is, if you belong to a zone which is maybe a green zone, you know, or maybe an orange zone, I mean, I would not really recommend for orange zone, but if you're itching to work, I kind of feel that this is a time where we need to understand that it's more important to be alive. You know, there has to be a mindset, you know, change, where we have to understand that what are the risk factors and what are we achieving in the larger picture. And I kind of feel that if we can just avoid and like sit put at least in the red and the orange zones for next 4 to 6 more weeks, according to me, it's more prudent. Green zones, if we want to start working, then I kind of feel that it's very, very important that our PPE is with us, because PPE is our only savior. So basically, you have to have the N95 mask, you have to be having the goggles, ideally the shield, and you want gloves and gown and, you know, head cap, these things while you're sitting in the OPD and taking rounds. And when you have surgery, of course, you have complete PPE that is required. You want to keep on sanitizing your hands, and you want to maintain a distance from patients. These three things go a long way. Very, very important.
Right. Dr. Amita, let me just put it this way, that the peak is yet to come in Mumbai. And do you really feel that all the other cities have already seen the peak and they are going to see a downtrend in cases and they can be allowed to start elective work there?
No, so actually the thing is that right now the places which are good have started opening up. For example, Kerala opened up. A lot of migrants are going back. And if you know, in Kerala, they had 184 cases in one day. And suddenly the numbers are going up. So the thing is that I feel that as the opening up is also happening, the numbers are going to increase. So my advice is that just avoid for next 2 to 4 weeks, just avoid, even in the areas which are a little lighter, unless the surgery is really required and the patient is in terrible pain.
Right. I think the message is clear. Emergency work still takes the precedence. You got to continue doing emergency work. On the other hand, I'm sure Dr. Trika has a different word to put across. Dr. Trika, you just mentioned that AIIMS has already laid down some structural changes and they are probably going to jump up the gears in a week's time. Your word on that. Are we really ready to take up elective work given that we are yet far from the peak in India?
It depends on what scale you want to start. The first thing which we have to know is where we are standing right now and how we plan to go further ahead from this. If we are able to take stock of the situation right now and then plan for our future, and then it will be, I think, much more systematic in our planning. We feel that right now we have got enough information regarding the COVID infection and how it spreads. So if we are able to slightly scale up our indoor or outdoor patient activities, we would feel that we are equipped enough to face that and then build upon that and subsequently go further ahead or take a step back, depending upon how it goes. As Dr. Amita had said, the situations will be different at different places. Mumbai is having 25 to 30,000 cases right now. So it's a huge task for them. But if we are able to just scale up for the last 2 months what we have done, and we are just trying to add one more thing to it, and then see how we fare, and then we take another step ahead or back. So that's what is our plan. And that's what government is also doing in a stepwise manner. It's opening up the economy, opening up the country based on what it is, how the things fare. If we are able to get up, take stock of the situation, gear ourselves up and work ahead, fine. If not, let's not hesitate to go back one step, prepare ourselves again, take it, and then go ahead sometimes later.
I think it brings in, yes, Dr. Amita, your word on that. Yes, Dr. Amita.
A point very well taken. Dr. Vivek. It's a very good thing that what you're saying, but I kind of feel it's not only about our protection, it's also about the patient's protection. So at least in Mumbai and Maharashtra, there is so much of asymptomatic carrier going around, and there is just no way of knowing who's an asymptomatic carrier. So we may be completely prepared with our PPE to protect ourselves, but we all know that asymptomatic carrier undergoes a surgery. He has a very high chance of morbidity and mortality. So are we really justified when we are about to peak to go ahead with elective surgeries? So according to me, it's not only about we sitting at home and getting bored. It's also about we harming others, which according to me,
the point is very validly taken. Yes, I'll come to you, Dr. Chetan. I think that there has to be a clear-cut objective of waiting. If you are waiting, you must define why you are waiting for. You really need to gear up your preparations, and if you are ready to get implementation done, keeping the safety of patient and also the doctor paramount, if you can get all these points, I think that's the time when you would want to start your elective work in the green zones. So mind you, all these panelists are probably trying to bring out all the factors that are very important before you start considering your elective work. It is good to start work. However, you may really jeopardize the overall health care, and the fear among patients may only exponentially increase if you don't take into consideration all these points that have been just highlighted. Dr. Chetan, you had just had a point on that. Dr. Chetan, over to you.
It's not just about feeling bored or itching to start. There have been a lot of directives from the government, especially in the media, that why are the clinics being kept closed? I mean, even the patients have started asking questions now that why are you keeping your clinic closed? Because the media says that if doctors do not open up their clinics, they'll be punished. And people who are not working, doctors who are not working, are liable to be prosecuted. How do we deal with that then? I fully understand that if your clinic is in a containment zone, or if it's in a red zone, then you'll have to keep it closed. But then otherwise, there will come a time, and I think it has come now, that we should start working with proper protection and proper guidelines.
Yes, very important. Dr. Shushu, Dr. Chetan mentions that there are, on one hand, the risk of having problems during surgery and getting infected. On the other hand, there are government directives to start work or get punished. On the other hand, there are ailing patients who are genuinely suffering. Just yesterday, I saw a patient has been really crying, and the only way out is to either take him for surgery, and temporary measures just not working. So with these sufferings in mind, government directives on one hand, where do you see the balance happening in this era where we are yet to see the peak? Dr. Shushil Babulkar.
Vishal, I think what we need to understand is what is peak and what is lockdown. The peak has already started. We are right on the wave of that peak, and it will go on till we flatten it. Number one. Number two is lockdown is a strategy which is political and social, so as to up our admin and so as to have some SOPs at place, so as to have the medical ready for receiving once the lockdown is taken care of. Now, during this last 6 weeks, when we have been treating trauma, we have realized that it's not too bad a mortality and morbidity that has been published, which is 27.5% published data, which created a fear in the mind of orthopedic surgeons in particular, that let's stop this elective because bloody hell, it's 30% of mortality if we do surgeries. So let's stop elective. Let's do only emergency surgeries, which have been defined now well ahead, and we are doing only those. But then that 30% should have and could have occurred even in those set of patients, which is not happening. So last 80 fractured neck of femurs, which we did in last 6 weeks, the mortality and morbidity is close to 2.5 to 3%, which is way down from the projected published data from Wuhan, which is 27.5%. So we need to rethink. The mortality also is related in those 27.5% to pre-existing pulmonary cause and comorbidities. So if we take that section of patients away, if we start operating on young fractured neck of femur, or let's say elective surgery, young AVN, stage 4, young guy, no comorbidities, no respiratory distress, nothing there, plain simple elective total hip replacement. Let's start with those. But let's start going ahead with some kind of elective surgeries and start defining our limitations. We will not touch those elective surgeries which are high risk. Of course, we have to take patient in confidence. We have to explain that up of the risk which patient is willing to take with you and me. You have to explain that explained consent has to be there.
Right. I think Dr. Shushruth has stirred the while again more. Dr. Ramchada has a word on that. Sir, we are at a point where Dr. Amita says that we should wait. I'm going to catch Dr. Amita to ask exactly what should we prepare while waiting game is on. And while Dr. Shushruth says that we should be screening our patient more meticulously and we should start getting and upping our game. Dr. Trika mentioned that you can do a acceleration, deceleration, keeping watch on your games and your results in time to come. Dr. Ramchada, over to it, and then Dr. Amita, your word.
I am asking a question to all the panelists. Put your hand on your heart. What are the chances of you operating on a patient today who looks to be RT-PCR negative but has a chance of becoming positive in 5 days or 10 days as compared to 1 month back? Am I clear about what I'm saying?
Yes.
Sushruth, we are having a large increase in number of patients coming who are now contacting it and are asymptomatic carriers, much more than they were a month back. Are we in agreement on that phase?
Yes.
Absolutely.
Hence, the chances of us in the next 4 weeks operating on an asymptomatic carrier who may in fact even be RT-PCR negative when we operate, but can turn positive 5 to 10 days later is higher today and in the next 4 weeks than it was a month back. Now,
Okay,
extrapolate.
Dr. Ashish, you are the youngest of the lot. You will have to take this question first. What are the chances of you operating on such patient who's RT-PCR negative? Say for tomorrow, you get a tumor patient coming to you. How will you proceed from here there?
Yeah,
Let
so
me
I'll tell you our experience from.
Dr. Ashish, wait, Dr. Ram. Yes.
Vishal, so today, if I have operated on a patient who today is RT-PCR negative, the chances of him turning positive a week hence is higher than it was a month back. Hence, the data of mortality, that mortality is related to patients who are found to be positive later.
Yeah.
The chances of them being positive later today is much higher than a month back. And I would agree with Amita that we are still not on the top of the peak. We have not yet peaked. We shall be peaking in the next 1 month. This is the way I look at it.
I think Dr. Ram.
I just want to talk here in between. So in response
Yes.
to Dr. Chetan, he was saying that the government is pushing us to work. So we need to understand that government is pushing us to start consulting. So consulting is not doing surgery, right? So if your clinics are closed, you can restart your clinics and you can start consulting. So you cannot equate starting clinics to operating. And this I want every orthopedician to understand. Government is not asking us to operate, number one.
Right.
To talk
Right.
about the
Dr. Amita.
surgery. Sorry?
Dr. Amita, since we are on you, can you please take my question on that? You and Dr. Ram both are on one side, and we already have a bias here that there are guys who are ready with their safety norms in place, implementation of the protocol that already existed. What more should all these guys be doing by waiting? Like if tomorrow, 4 weeks more, government comes up with this
That's
lockdown.
what you interrupted me. So 1 second. So I spoke about Dr. Chetan talking about the government pushing us to work. So I'm again repeating, it's pushing us to work. We start doing OPDs. It's not pushing us to operate. We cannot conveniently understand what we want to understand. Second part, talking about the surgery and the mortality. Basically, this mortality of 2.5% is not correct because we haven't done an RT-PCR on this patient 3 or 5 days later. We have done one PCR which may have been negative. So we really don't know how many of these patients were true asymptomatic carriers. Probably these patients who have been operated upon were clearly not the carriers. So this 2.5% mortality is completely rubbish. And I refuse to accept this. I mean, whoever is talking about this 2.5% mortality, please tell me how many RT-PCRs were done for the patient and how many of the patients were truly negative. We cannot
Can I take that?
data to suit our purposes. We cannot do that.
Okay,
Can I
Dr.
answer that,
Yes,
Vishal?
Dr. Ashish. Yes, Pandit.
Yeah. So Also to answer Dr. Babulkar's this thing also of 2.5%, even we audited our surgeries across the specialties and orthopedic surgeries as well. So we've not done the numbers that they have done. But I agree with Dr. Amita that there was a time in March after the lockdown, April and the beginning of May, where we were not seeing those many patients. We have not screened any patient. We have started screening only from the 1st of May, when the ICMR said that you can screen asymptomatic carriers. And since then, the shift is so visible that we are having at least 10% of our patients who we have to shift to COVID positive hospitals. And we fear that the mortalities will now start coming in. There was no talk of any mortality. We have not lost in Thane. I'm talking about the entire district of Thane, including New Bombay. No orthopedic surgeon has lost a patient to fracture neck femur in the month of April. But now we are seeing more and more patients being shifted to the ICU, long stays, developing pulmonary complications, not coming on the table because they are having some problems. So I think the mortalities will start coming now. What will be interesting to see, Dr. Babulkar and all of us, is to see how the mortality data keeps on changing in May and maybe the month of June.
Okay, I think we already have 3 on 3 now. We have Dr. Amita, Dr. Ram, and Dr. Ashish saying that we should wait a while before we actually go and start elective surgeries. And we have Chetan, Shushrut, and one more guy to say that yes, we should actually step up our game, and if we are ready with our protocols, we can go ahead. My question to all the panelists here: what if we are able to implement the current guidelines? Today we are at 25,000 in Mumbai. I am sure the numbers are only going to increase. And for coming 3 months, even if we are able to plateau the peak, the numbers will have a steady increase. So in coming 3 to 6 months time, shall we continue our wait game, or we should up the game and be able to implement the protocols more stringently, like we are able to do emergency cases safely, and in the same protocol manner should be able to do the elective cases in the same safety environment? Is that also a possibility, Dr. Amita, Dr. Chetan, and Dr. Shushrut? How do you see things happening from here? Dr. Amita first.
Can I barge in and give you one parallel?
Dr. Shushrut, I'll come to you. Dr. Amita. Yes, Dr. Amita. So my question is, with the same protocols, can we implement them, make quality control measures more stringent, have safety control measures stringent, and work every case like we are doing emergency cases today?
Okay, so Vishal, basically, according to me, we have to be really having a very stepwise approach. So we can't say that next 3 to 6 months we won't be able to operate. According to me, the priority is not only our infection, priority is patient's life also. If we understand that bottom line, then I think we're going to be very, very doing a justifiable job. So I kind of feel that right now everybody's thinking about, if I operate, I need to be safe. But when we are kind of peaking, once we peak for 4 weeks, at that time, every patient is going to be under dire straits. So basically, according to me, for next 6 weeks, we should not be thinking about elective surgeries. According to me, right now, please have protocols for emergency surgeries or urgent surgeries. But to want to start elective work, at least in the red zone area, especially Maharashtra, Jaipur, Delhi, according to me, is being unfair to the patient, and I don't accept it.
Dr. Trika, since Delhi has been mentioned, AIMS protocols are there, they are being laid down. What is your take on this? When will you be able to implement the protocols and start your elective work safely?
Let me make it clear. I think that there was some confusion regarding what I was saying. What the government of India is saying to everybody out here, and we being the premier institute next to the government, so we are in the hearing line the first, is that you have to step up your work. We are opening up, we are looking at emergency cases. And as Dr. Amita has said, what I was saying, that we are taking one step at a time. It is not that we are increasing our surgical numbers and volume one step at a time. We are looking at the health perspective in its entirety. And now we are already started up, like, let me tell you, AIMS never stopped their OPDs till date, 60 years. On 24th of March, we stopped our OPDs, physical OPDs. Now, again, in April middle, after 20th April, we started the telemedicine thing. So that's one step ahead. Now, after 20th of May, 1 May, when we have completely taken stock of the situation with our resources, our infrastructure, now we are planning the next step ahead, which is our OPDs, the physical OPDs, which we have to get and which we have to see for the patients whom we require to see physically. So that's the next step ahead. And if we are able to get that in a semblance of standard normalcy without any increase or very high increase in the volumes of COVID patients or causing harm either to the patients, relatives, or to the healthcare professional both, then we plan to step ahead and start the semi-elective. Remember, there's nothing like elective right now, but you can start. That's a stepwise manner that you have to start that. And then once you have taken care of your emergency cases, your physical OPDs, which have to start, we are just thinking of orthopedics. Think of the other patients who really require to be seen in front and then done the physical OPDs. So they start, then we start for the semi-elective. And I think the pure elective cases, which were done for the quality of life and in the end cosmesis, they are going to take a long, long time there. You will have to change your professions if you really want to earn money through that.
Right. Dr. Shud, your final comment on that. Are we really ready to take elective work? And if yes, what magnitude of elective work, like Dr. Trika and Amita have classified it, what is the type of elective work one should actually take from here?
So let me again reiterate what emergency is and what elective or semi-elective is. Of course, whatever elective or semi-elective which is meant for improving the quality of life as Vivek has suggested, will 4 months, 6 months can easily wait. Whatever can wait, of course it has to wait. There is no doubt about it. What I'm trying to suggest is emergencies has already started. OPD we have already started everywhere. Emergency patients we are already doing now. The data which emergency trauma patients are giving us is far way different than already published data of so-called virulent COVID cases of China or Europe. We are behaving differently. That's one way of looking at the whole situation. Second way of looking at it is, if we look at the parallelism of Ebola times, less people died because of virus in particular, more people died because of all parallel problems like hunger, poverty, and etc. etc. So we have to get the cycle going also parallelly. So what we are doing in Nagpur as against Mumbai is, tomorrow onwards we are looking at part of Nagpur getting opened up, because we are in green zone part of it. We have no cases, we have no transmission, we have no hidden cases also, we have no carriers also, because the testing has been done. So for that sector of patients, we can step a little up, like Vivek has suggested, to semi-elective. So what is then semi-elective? We have to really go down.
Yes. I think Shushruth, very well taken at this point. There are multiple slides and sectors of discussion that are going to come up, but at this point, I think the emphasis is very clear. And I really thank all the panelists here for bringing this point up, is that on one hand, there is doctor's perspective that we will be forced to work. Yes, you will be forced to work because there are ailing patients there. And remember, once you lose the trust of patients, once you lose the benefit of the patient's trust, you will probably not be having the same kind of patients coming to you. And this is the time when you would want to gear up, step up your care. That doesn't always mean that you would want to start elective surgeries. And again, choice of elective surgeries depend on multiple factors, whether you are in green zone, whether you're in red zone, whether in your zone testing facilities are good or not, whether your hospital is prepared enough to undertake that kind of preparation or not, whether you have your own SOPs or not, whether your implementation is having quality control or not, and of course, whether you are seeing such kind of asymptomatic carriers in your practice or not. And all these factors taken into consideration should be kept in mind. Mind you, safety of the patient and doctor both is paramount. And remember, financial burden is something that is only going to hit you once you start this. So the idea is, keep watching your own results, keep watching your locality, keep watching the number of patients you save before you really jump into elective work. But yes, don't forget that emergency work has to take precedence. And of course, you may want to start consulting your patients. Keep the trust of these patients alive. Coming to my second part of the scenario, now we are all going to be jumping into a situation where lockdown will be over. We are already following some protocols, and few of us have started clinics, and there are certain protocols we followed, and we have already seen that some healthcare workers have also got infected. So Dr. Fandis, what do you think in consultation? I mean, is it going to be as simple as it has been, like appointment given, consultation done, prescription handed over, and it's gone, and some safety norms, I'll wear a mask and it should be done, or we will have to change in a gross way? infrastructure wise, protocol wise, safety will come into parallel? Dr. Fandis.
Yes, I think a lot of changes will have to be done from a patient safety point of view and a doctor safety point of view as well. So, as was laid down in the protocols, that you need to wear a PPE, space out the appointments, and there will be a whole change in the culture of consultation as well. Consultation with 5 or 6 relatives, I don't think it's going to happen right now. It's just going to be consultation with a patient and maybe one relative. Then even multiple contacts, like the fellows taking the history, then the resident examining, and then the consultant coming. So it's going to be only one person consulting, giving the treatment, and maybe electronic prescriptions, which is what we have moved on to. So not much handling of papers, x-rays, folders. Everything has gone on the screen, electronic. Space out the appointments. We are seeing only 4 patients per hour, so that gives about 15-minute intervals. So we are operating probably at 1/3 or less than that of our capacity at the moment.
Right. I think there has to be a major shift in the way we used to manage orthopedic patients, and only management of orthopedic problem is not the call of the day. It is now the management of safety norms, both of the doctor, also the staff around you, and also the patient. He should also not contain an infection in the vicinity where you are practicing. So Dr. Ram, you have been doing teleconsulting. Do you really feel that electronic consultation formats are as gratifying to you and also to the patient, or is it just by force that is happening today?
Well, I'll be very frank with you. I am very clear now that the new normal is going to be a primary consult, which is a teleconsult. The teleconsult is going to be a triage. A lot of patients could be handled primarily with a teleconsult, including my back pains and neck pains. Maybe out of 10 patients, 3 or 4 may need a face-to-face consult. This need not necessarily happen immediately. This could be after 10 to 12 days of non-invasive, non-face-to-face consult-based treatment. There will be, however, some very, very few, like a cauda equina or severe pain, a malignancy, something of a fractured spine, who would need an immediate face-to-face consult. But the new normal is going to be a teleconsultation, reassuring, counseling. And I have actually reached a stage where I'm extremely happy. There are a lot of things actually can be done on a teleconsult, including eliciting the signs that we need to look at, including a lot of things which we thought otherwise were impossible. Necessity is the mother of invention. And believe me, maybe a week from today, we can look at the details of teleconsultation and plan how to do a good teleconsult. And that's the way forward. But that's in a setup like ours.
Who thought 5 years ago, just 5 years ago, who had really dreamt of Amazon, Flipkart, Myntra, and various online platforms selling right from the undergarments you wear to all the fashionable clothes that you have, and day-to-day wear, and the groceries and everything that you can name, and everything is available online. So why not a consultation? And that's the future, like Dr. Ram just mentioned. Mind you, yes, it may not be gratifying earlier, but sooner or later, you'll have to embrace this form of consultation and treatment options before you really see these patients physically in your clinic. Dr. Chetan, can you help us understand now? We are going to step up, and there will be many, many patients in a country like India who are not so friendly with telemedicine. What kind of changes should one bring in practice, in infrastructure? There are at least 20,000 clinics in only city of Mumbai. For all those guys who are here, can you tell us what kind of infrastructural changes and protocols one should follow in physical consults at the clinics happening?
Yeah, so there are a lot of changes which will be required, or which have already been starting to get implemented. The first one is not a very crowded OPD as it used to be. We used to always hear ki more the crowd, more famous is the doctor, etc. Now it's going to be the other way around. So you should have a clear cut, like Ashish said, maybe 4 or 5 patients an hour, and no waiting in your OPD, no relatives accompanying that person. You should have your reception who is manned by well-protected people, protected in the sense they are wearing their masks, their face shields, their gloves, asking a basic history of maybe fever or cough or respiratory tract infection. If that is so, then that patient will not be sent into the chamber of the consultant. Then sanitation of the patient coming in, like giving a hand wash or a hand sanitizer and asking him to wear a mask will be mandatory. Not bringing a whole bunch of x-rays, but what is most important or the latest one, or preferably doing paperless as we are doing it in Sancheti in Pune, that we prescribe an x-ray, we see it on the laptop or the computer, and give an electronic form of a prescription. The consultation room itself needs to be changed. You should preferably be having 2 consulting rooms so that one can be cleaned or sanitized immediately after the patient leaves with 1% hypochlorite or an alcohol based solution. Rexin covers on the patient surfaces. Your tables have to be clean. So every patient, once he leaves, that surface has to be clean. And then, like was mentioned, no teaching, no residents. Do a quick consult if it is required face to face, and give an electronic prescription. So these are
right. I think both Dr. Ashish has mentioned that there has to be a major shift in the way you need to practice. On one hand, you have to up the game and you have to start elective work in form of routine consultations to reduce the ailing patients who are suffering really from a long time. On the other hand, there has to be a major shift in the management protocols. Dr. Ram highlighted about the need of teleconsultation and the changes just highlighted by Dr. Chetan Pradhan. Dr. Ram, your word, you have a quick comment on that. Dr. Ram?
Well, I think we have looked at a Mumbai scenario. We've looked at a tertiary care scenario from Pune, which is Sancheti Hospital. We must also look at what people elsewhere outside Mumbai and Pune look at it. So I would want some inputs as to the way forward from Dr. Ajit Shinde and Dr. Narayan Karne, both of whom represent the state of Maharashtra, as to where we are today and how things are going to change.
Dr. Karne, your word on that. What protocols should one follow while doing routine consultation in the periphery of Maharashtra and country?
It's muted.
No, your answer.
Yeah, okay, fine. Thank you, Vishal. Because I'm listening to all the discussions, and this discussion is an ideal one in ideal scenario. Now we have to take a certain consideration into the mind. See, as just Ram said, that we can take all these things in the institutions and the hi-fi institution which can do it. The one more important thing is we have to see the class of the patients. We are ready to do the teleconsultation, but whether our patients are intelligent enough, how many of them are doing online marketing or buying? If they are doing online buying, the malls would have been completely empty. So we have to consider 2-3 things. One, going back to the basics of this asymptomatic carrier. I fully agree with Madam Nene, but then how long this asymptomatic carriers will be there? 1 month, 2 months, 1 year? How long? And how long we are going to get afraid of those things? That is one part. Second part, as far as OPD is concerned, see, it's all right for those who are having 10 or 15 OPDs in a day, but for many doctors who are having 80 to 100 patients in OPD per day, how they are going to do all these things? We can take care. We should come midway somewhere in between all these things. Doing everything electronically, doing everything, as you said, with the telecommunication will not be possible in all the nooks and corners of the Maharashtra. So this particular discussion should be taking into consideration those people also. So we have to take precaution. Why we are scared of all this, even in operation theater for the droplets? Are we not operating HIV patients? HIV patients are rather more, infective as far as blood droplets are concerned. So what are precautions we are taking when we are treating the HIV patients, hepatitis B patients? Same precaution we can take now. So what we have to consider, one is a patient at the periphery, second at the small nursing home owners, how long they are going to take this precaution. We are hoping that peak will go down, but I think peak is yet to come. And we don't know the way the social scenario we see all around us. The moment you lose the lockdown, there are hordes of the people are moving around everywhere. How you are going to stop all these things? And it's not that the patient comes.
Dr. Karne, I'll just like to highlight a story here. A story from one of very, very close friends' nursing home in Uttar Pradesh. He unfortunately was also doing routine elective surgery just 2 weeks ago. And he also was following the norms of universal precaution using HIV kits during surgery. Unfortunately, he being the surgeon, his wife being the anesthetist, his son being an orthopedic surgeon who was assisting him in the surgery, all three were infected. He himself is in ICU at this point. 43 staff members from his nursing home are all infected and quarantined. and he's at the verge where complete lockdown of his nursing home has already been done. And this is something that was in my mind while planning this webinar there, that on one hand, safety is paramount. On the other hand, we have to up our game to get elective. On the third hand, how do we make the protocols of safety is something that we all will come in. Yes, the most pertinent point that you mentioned is, yes, in the nooks and corners of Maharashtra, probably online thing is not possible. People who have had busy consulting so far may see equal number of patients. It's like alcohol shop opening and getting the whole trunk there. But again, we have to ensure the safety, not only for the sake of doctors and healthcare workers, but also for those patients also. Dr. Amita, your word on that.
Yeah, so once again, I'd just like to clarify a few things. Thank you, Dr. Karne, for your important inputs. I want to say something very important. HIV and Corona are just not comparable, and I want everybody to understand this. You cannot say we were operating with HIV and hepatitis B because they are completely different ball games. Over here, there is droplet transmission, and during aerosol production, it is much, much more. So HIV and hepatitis B is by body fluids. This is by inhalation. So Corona is 10,000 times more infectious. We need to understand that. So if we were operating on HIV positive people, it's a different thing. But Corona is a totally different ballgame, which everybody needs to understand. Number one. Number two is that we need to understand that we need to slow down. Our returns are going to be less. We have to get used to the mindset of seeing a fewer patients. It is not only we seeing few patients, even people who are waiting outside our OPD. Our appointments have to be planned in such a way that at a given time, not more than one person is waiting out. Only if you are going to be able to manage these things, then only open up your clinics. So you have to call patients by appointments. Everybody is sensible. Nobody is as silly as we think they are. You know, today, my most dumb patients also send me WhatsApps, and they have been sending me reports 1 year back also. They are smarter than you and me can think. If they can't do telemedicine on the computer, you can easily do a WhatsApp video call with them. They know more than us how to do it. You know, so according to me,
right. I think yeah, it's the future of the game, and I think we'll all have to up the way we have been practicing, and probably
there can be no shortcuts by arguing that people will not understand. Try to make them understand. Everybody is sensible enough, you know. So,
I think every crisis brings in an opportunity, and probably all those guys who have been crying that my clinic is disorganized probably can use this crisis as a chance to revive their practice into a far more organized manner. Now let me just put in this way now, Dr. Chetan, what is your safety norm while you are doing consultings for last 1 week? What is the way you sit in your consulting room? Do you use N95, a simple mask for your patient? What is the safety norms that you follow?
Yeah, so I'm following the guidelines which we discussed in the last webinar on the 1st of May. So I give, like you said, just 4 appointments in an hour. I'm consulting for 2 hours only in my clinic. And that also I started just this week. Before that, I wasn't consulting at all in the clinic. So this week I have started. I'm doing it alternate days, and I'm seeing only about 15 patients. And I'm wearing a mask N95, I'm wearing gloves, and I'm wearing a face shield as well.
Right. Dr. Karne, do you wear PPE in your clinic, or you intend to wear PPEs in your consulting chambers where you are going to see larger number of patients? Dr. Karne?
They're muted, sir.
Yeah.
That is what next I was going to say, that accept all these things about the corona and take precautions at every level, right? In the entry to our hospital, we start giving the patient the mask as well as the sanitizer on their hands, right? From the entry of the hospital. Similarly, while seeing the patient in the clinic, there is no need to go in a complete PPE, but we can have the gloves and you can have a face shield as well as a mask and the cap.
Perfect. Dr. Shushruth, what is your safety protocol in your consulting room? How aggressive are you to break the chain of transmission between you and patient?
I'm actually far more aggressive than any one of us here actually. Right at the hospital, outside the hospital, in fact, there is a barrier. My guard checks the temperature. My guard gives the sanitizer. They come in the second barrier, they get a mask. The third barrier is on the reception. They are already having the appointment. Per hour, only 3 patients. They are made to sit distant apart in the waiting room. I have stopped my routine consulting chamber. I go and see the patients in a separate corridor, which has a separate entry and separate exit. So my normal entry and exit is separate. This is another entry and exit to patients for OPD. I wear as Chetan. The only addition is a cap, Chetan, which you forgot. So cap, the mask, face shield, gloves, which need to be, the gloves need to be changed. I change the gloves. I don't do sanitization. I change the gloves after every
Patient.
patient in the OPD.
So Dr. Amita, we saw that 4 gentlemen having absolutely 4 different kind of safety norms for themselves and patients being treated very differently in different setups. What is the bare minimum? I know maximum can be being in full PP, but how do we triage the resources and what is the bare
So
minimum?
I think the important point everybody forgot to mention, which I'm sure they all are wearing, is a gown. A cotton gown is a must. So basically what we do is the minute we enter the hospital, we first sanitize our hands, we put on the N95, and then we change into hospital scrubs. And on that, we wear a cotton gown and we have gloves. We definitely have a cap, because at least I have a habit of putting my hands into my hair all the time. I prefer a shield over goggles. I find the shield more comfortable. It also covers my neck that way, and I prefer to wear a shoe cover also. So basically,
Right. I think we need to understand the transmission chain here. While I'm just taking off my slides and Dr. Vivek Trika, who's none other than the person who has actually devised all these OPD protocols, may I request you to pull your slides up here? We need to understand that the transmission purely happens only by 3 routes: eyes, nose, and mouth. So these 3 orifices have to be completely covered either by goggle or face shield, along with the N95 mask and a mask over that and a cap there. Gloves changing may or may not be an absolutely essential part. However, hand hygiene is very, very important. And remember what is commonly said in orthopedic practice: we are all boys, and boys don't touch men. Mouth, eyes, and nose. No touch technique for men, and you still keep your hands away. Keep washing your hands after every patient is absolutely mandatory, and that's bare minimum. You may not necessarily wear the PPE. Your staff may not necessarily wear the PPE. The receptionists do not wear the full PPE. There are various gradings of it, and I'm sure Dr. Amita is going to throw highlight on that. Dr. Vivek Trika, OPD consulting. Where do we start? How do we follow? Over to you, sir.
Okay, thank you. I prepared this around 2 months back in the first week of April, and I have been speaking this all the time for so many 2 months now. I'll just start by saying that once we are dealing with a calamity, we have got this sort of an inverted pyramid where we can work. We can eliminate the virus, we can substitute the virus, but these 2 things are with the help of microbiologist or a vaccine. The rest of the 3 things, the engineering controls, the administrative controls, and the PPE, these 3 are the things which are under our control. So remember this. And remember that PPE is a very small or the lowest part, because that is for protecting our own self. The more important is the administrative and the controls and the engineering thing, which will isolate the people from the hazard. Whereas PPE is protecting the worker and the healthcare provider also. So just understand this, what we are trying to do. Our protection or the protection of the society at large. If we look at this, OPD guidelines, this is what our usual OPDs used to look before Corona. And that's the biggest problem. And that's why the government is slightly hesitant, and we are hesitant in our hospitals to start this in a government setup where we have a OPD of 5,000 patients. The railways are starting just now in 1st of June. The airplanes might start from 25th of May. That's how the hospital can also be a biggest source of infection transmission if we do not take the precautions. So we have to understand where we are working and what we are dealing with. Is it a hospital work setup, or it's a private setup with a small area and less number of patients? But remember, one thing which we all have to do and should have done by this lockdown period was planning and funds allocation, which is required for our OPDs. If we start planning now that we are going to allocate our funds and divert them and make the new things now, that's going to take some time. And we need to ensure that this is going to be there before we start looking after the patients in our outdoors or somewhere else. The first thing for bigger hospitals is marking, and you will have to have more people. As I said, more funding is required now to allocate for these things which we were never considered so important till now. And you have to ensure that people are standing in lines. People may stand in line in front of a liquor shop nowadays, but they also will have to stand in front of the outdoor patients registration, which is very important. With Corona is there, after Corona is never going to be there, at least I think in our lifetime. So we will be living with Corona now. The thing is appointments, and that's what we were discussing. Appointments have to be made, sir. And even in Mumbai and in Delhi, if the railways, people who are trying to go, the migrants, they come to railway stations just by a phone call which was told to them or by a message, and otherwise they are not thronging the railway stations. The same way the hospitals need to be done. You will have to ensure, and everybody can do it. If a migrant and knows that he gets a phone call and he rushes to the railway station, the same way a telemedicine can be adapted and made sure that the person gets to his healthcare needs by the hospital when he gets a phone call from there. We have to have those phone calls ready. Tell me how many people in this panel have their phone numbers of their hospitals, which is known to their patients, who can tell and call them up saying that I want a clinic referral or an appointment tomorrow or even the night. That's what is planning, and that's what we need or should have done in the last 2 months, and should now also do that. Inform the patients that this is the number where you can get your appointments. Televise it, advertise it, or whichever way under the norms of medical ethics, but do that for the hospital, which is paramount. If possible, these are the constructional or engineering things which you can do. You will have, in a big hospital, you have to have the screenings, as was told by Sushrut, that you can have your first pre-screening and then you can enter. In the big hospitals also, the screening area has to be separate. And then once the patient goes through the screening, then he is able to enter the OPDs and the other things. Everybody has to be given a mask and only one attendant for people who really require the help. Sanitizers for all. And if possible, if you have those structures, like in a passport station where you go, people come through appointment. Previously, we used to go to passport and we had to have waiting for so much. Same way, come through entry gate and then leave through a separate gate. The persons going in and coming out need not come through the same gate if possible. This is mandatory nowadays, and all the small clinics will have to do this. Your person or the security personnel who is standing outside has to have the protective equipments, protections, the gown, the mask, the head shield and the face shield and the head cover. He screens the person, gives them the sanitizer. If you feel that you can also have hand washing system done right in front in the bigger places, and this will be the new norm for the smaller clinics. Registration counters will have to have physical barriers. The next barrier after the mask and the hand sanitization and the screening of fevers is going to be your barrier of registration, where the telemedicine is going to be seen. That needs to have a barrier. You will have to have the glass mirrors, glass shields, or plastic shields, which have been put just like in any other banks or registration areas, which needs to be done now. Remember, we are in the Epidemic Act right now. So that is helping us to go and treat patients, and they may not be able to catch us if they get COVID in the hospitals, because this is what we are doing for the country and it's under Epidemic Act. But after this Epidemic Act also, you have to have a questionnaire as well as a consent form for everyone who is reaching your hospital, that if he gets the hospital problems through COVID, he is not going to sue your hospital. You will have to have this consent, maybe not now because this is under Act, but later on you will have to have this thing written down so that you do not face unforeseen medical legal problems. Buffer zone, as I've already told, no crowding in the waiting area. Appointments have to be done if you are a big hospital by your calls or the coupon system. We'll have to go and understand how the liquor shops have done that. Online system by all the governments. Previously, there was so much crowding, but over the next 3 days, everything has fallen into line. They are being given online appointments. They are given 500 appointments a day, and people go at a respective time to the liquor shop and take their things and come back. That's how we'll have to have our OPDs also. If the liquor shops can do it, why can't a hospital or a private clinic do it? Inside the OPD, the sitting has to be different with social distancing. either you have your ragzin of your sofa covers changed to different colors so you know where the person is needing to be sitting, or you tape them or put in plasters or in posters saying that nobody is going to sit here by signages. Different colored seats can also tell where the person is sitting in your OPD areas. You see, this is from, I think, from Mumbai itself, that how the police people are doing and sitting in a bench. That's how the people will have to be saying that the middle one is kept empty and they're at least keeping 6 feet distance from each other. The lifts have to be specified if you have in your hospital, which are the corona lifts or a suspect list and which are the separate lifts. And inside also the lift, you will have to have social distancing being maintained by putting in markers everywhere. For the waiting areas, use as much as health precautions and health awareness things which you can get. You should have health sanitizers and hand sanitizers available freely in that area. Do not have, as was done by Sushrut and by Chetan regarding your OPD setup, do not have more than 2 or 3 persons per hour. Make sure that there is a gap of 15 minutes between each OPD person who is coming, so that you have the time, if you require in a small setup, to at least sanitize the area where the person was. Open up your windows, let the airflow be there, and then see the patient after 15 minutes or so. Let the thing settle down. Do not, because remember, you are sitting in that room for the next 6 hours or 5 hours. The patients are coming in and going out. So that room may be filled with aerosols, which you need to disperse by giving an open air for them. Alcohol sanitizers are important. The third thing, which even I'm happy to see that even the airports have started doing this, which is going from 25th, that they will not be providing any newspaper or glasses in the airports or anywhere. And this is what is required. All the glasses which we give for the patient should not be steel or this. They should only be disposable glasses for drinking. Monitors for putting in the health screening and social distancing so that they become aware of what they are doing. The covers should be able to, you should be able to disinfect them by alcohol and by bleaching powder things, Raxin based covers which are there. Signages of dustbin should be very important, and medical legal waste disposal has to be informed to the patients, which was not done. Remember that in India now spitting is having a fine. That's, we always used to think that Singapore can do it. India also has now a law right now in many of the states at least, that you cannot spit on the road, you can be fined 100 rupees. That's what is required, and people will have to change their practices, the doctors as well as the patients, because we are after all the human being and citizens of this country. The chambers can be changed by making sure there is proper ventilation and aeration. You open up your windows, doors, so that the ventilation from the nature and the natural air is coming as fast as possible. Acrylic or grass barriers can be put around your table if you want, so that nobody is touching your table or your things as much as possible. But remember, then the CT and MRI films will be an issue. If possible, have a contact on online things if you can get them with a CD or something, and decrease the close contact with the patient for less than 15 minutes. A close contact is considered to be within 15 minutes nowadays. So you might ensure that you are seeing the patient for less than that, or you are taking all the precautions which are required. Sanitization is very important of your OPD area, very essential. Start cleaning from the cleaner areas and then proceed toward dirtier areas. Don't go the other way around and then start doing it. The high contact surfaces like the knobs, the doorbells, they have to be done as much as possible. For metallic surfaces, you can use 70% alcohol and not the bleaching powder, which may not be suitable for those shining things. And always use the freshly prepared bleachings and other things which you are using. Inside the hospital, if you have a small bed or small clinic or a nursing home sort of a setup, try to keep the distance of the beds also. You might have to take out one of the beds, make sure that the beds are now properly separated, and you are having adequate area in between the beds which are there if you are having 2 or 3 beds in a room. Adequate room ventilation with at least 12 air changes is required. If not, let's say that you cannot have these exchanges or air things. Put in some exhaust fans which are driving out the air from the wards. Exhaust fan can be put on the opposite side. Make sure that the portable filters can be taken or air purifiers can be taken. Else, exhaust fan, making sure that all the airs are being sucked out into the natural atmosphere. is going to be helpful. Remember, the nature and the air atmosphere outside can help us because it cannot stand in the normal air for more than 10 to for few hours or so, and in the Indian heat, not more than few hours. Personal belongings of the patient inside the ward has to be kept to minimum. Sharing of equipment cannot be done. Temperatures will have to be by thermal gun, not by the regular measures which we were using. Have to have good housekeeping and checklist. Any person who is coming inside the ward or your hospital needs to have, you need to have his contact number as well as his phone number, to understand if required whenever there is a contact tracing which might be required. It's not only the thing which you are going to do for yourself. Remember, as a society, as a health provider for this society, we have a responsibility for the entire society. We cannot be the persons or the plane or that women or the patient number 21 or 31 of Korea spreading the infection to so many people. And that's what is our responsibility. Let's not be in a haste to start everything, because we were blaming the malls, the cinema halls, the railway stations, and the airports till now for that. Let's not we become the sources of transmission to entire people by our things. Inside the ward rounds will have to be limited. Maybe you will have a ward round with your people in front before, and you will have to use the technology. This is from the China, where they're using the monitors just like this and seeing the patient first, and then going in once only to see and to have a physical or a mental, social well-being of the patient so that he feels better. Because remember, we are used to having physical contact, or the help suggest the nearness of the doctor will also provides good care for the patient. Dressings of the wound, remember, no daily dressing is required now, because that will also generate aerosols. Do not put very bulky dressings. Don't Robert Jones bandage over a patient with a suture line is not required. You will have to make a transparent dressing at the most for first day, 2 days. Leave it there if it can be, else apply some betadine and leave it. Do not make sure that you are removing the dressing, asking your residents or somebody to open and change the dressings every time. Foam dressings and negative pressure can be helpful. Decrease the frequency, which is very much required. When you are doing the dressing, you have to have a face shield in front of you, because you will, and the aerosol production is the next in the dressing changes, which can have those areas with the body fluids. Similar, not similar, but less than that of the aerosols, but still important for us. And as I said, this is what we might be missing out. We may not keep an entry of the patients and the healthcare providers and all the visitors who are coming in our hospital. If our hospital becomes or a source of this infection, we need to have the contact people who can get infected. So every person, be it your official, be it your visitor, be it your patient, his attendant, anybody who is coming inside, needs to be recorded, his number, his mobile, and when he came, because that is going to be helpful in the screening process later. These packs and online things, roaming around with a tablet inside your room with all the people, online things, you will have to change. It will help us to change to an online thing as much as possible. Just regarding the finally in the protections, the acceptable alternate is having a face shield, face mask of N95, sterile gloves or unsterile gloves depending on place you are, gown, coverall, shoe covers, and the head cover also. In OPDs and wards and the patient contacts, where you are going to have patient contact, make sure that you are having at least this, an N95 mask without a valve. Do not have your patients also who are having a valve in front of your N95 mask, because they are exhaling out everything, but they are protecting themselves, but not the society. Triple ply mask might be required. A face shield, I would say, is a better idea when you are inside the OPDs, along with the face mask, with the head covers, as well as balaclava or something, and the gowns which you are wearing. Nitrile gloves helps us, but even a normal glove can help us. You can have a normal unsterile glove for that matter. It doesn't change. As was said by Shrushruth, the best thing will be that you are not doing the OPD in a closed area. What we are planning in many places that your doors should not get closed until unless you are doing some private or examination and with the help of somebody. The doors should not close. You should have open doors in your small clinics so that the ventilation is there, which can help you not concentrate the aerosols to one area. The low risk personnel should of the security, receptionist, and the visitors at least should be wearing in resource constrained areas also a triple layered mask and gloves with the head covers if possible. These will be the bare minimum, if possible with a shield. That is the bare minimum which people should be having, and we will have to get used to this, because even if there is a place, or let's say 2 months, 3 months, 6 months later also, we will have these patients, and we will have to protect ourselves and the society at large so that we do not become the sources. Ultimately, what we are discussing is a balance, a fine balance between patient safety and your own personal safety, which we will have to do whenever, whatever, and how much we plan to do for this OPD setup or our healthcare provision. Thank you.
Thank you so much, Dr. Trikha. I think you have just elicited some of the very, very important points in consulting chambers, and I'm sure we are all going to be taking things forward from here. So Dr. Ashish, Dr. Furness, in your consulting, other than all the structure and the protocol changes Dr. Vivek mentioned, what are the other things that you recommend for anyone who's got a single standalone clinic where there are no triage points, where there are no change in the structure can be done? What is the minimum thing that you recommend for all those guys who are in their clinics and nursing homes with standalone single consulting rooms?
Yeah, so minimizing the number of personnel who are there in the OPD. I mean, if it's a female patient, yes, there is a chaperone. But for a male patient, generally is just the patient, his relative, and me who are there. And rest of the things, as Dr. Trikha said, I mean, I don't use a gown, but I use a mask and gloves and change the gloves in between the patients. But yes, getting the MRI, CT scans, everything has sort of come down. So the receptionist or the registrar just asks the patients to take in the relevant films if they are hard copies. Otherwise, everything is there on our on the packs. So even the prescription to the patient is printed out in a printer, which is there with the receptionist outside. So try to declutter all those models which used to be of the knee, of the hip, and fracture models which you used to demonstrate to the patient. All those, the clutter has all gone. It's just a plain consulting table, and just keeping a safe distance between me and the patient. Most of the consulting.
I think I'll just give you some examples around here. One of my very close friend who's an orthopedician in the northern suburbs of Bombay, he actually has started this coupon thing that patients come, take a coupon and go home. They only come at a very scheduled time that they have got, like Dr. Trikha mentioned, like by people who want to buy alcohol, they get this coupon thing on phone itself. You can just get a number and they can come and get their consultation. And I'm sure this is possible. And like we just mentioned, crisis brings opportunity. And this is the thing that in 2021 January, probably we'll be a little more organized and we'll save a little more time for ourselves. We'll have to invest at this point, both energy, time, manpower, and money to get more infection control from here. And in my own clinic, in fact, after every patient who books an appointment, Dr. Trikha would be happy to see that he already has a fan following in me, that I have already started following all this, and all my patients who book an appointment get this thing sent to them by email also and by WhatsApp also. They get all these notice both in English, Hindi, and Marathi, which has been typed, and they are given an option of direct consultation. Even in fact, they have booked a physical consultation appointment, and only then they are allowed. And we follow all these protocols that have been just highlighted around here. Now, coming to the masks here, Dr. Amita, there is a whole lot of things happening around. I see some of my orthopedic colleagues wearing those modern respirators. There are guys who are wearing those motorized respirators. There are guys who, so everything in this world is a mask. A burqa is a mask, a handkerchief is a mask, a thin kapda is a mask, a green kapda is a mask, N95 is a mask with a wall, without a wall. So can you please highlight for a receptionist, for a consultant, and for a patient, for all these three, what are the basic requirements of a mask? We don't want to overuse it, also not want to underuse it.
Okay, so I'm going to say something from AIMS guidelines, because according to me, they're really sensible. So the thing is that any person who's a healthcare worker, so healthcare workers are not only doctors, so technicians, nurses, secretaries also become healthcare workers. Each of them should have an N95 mask. I mean, you cannot have any kind of shortcut over here. That is number one. Okay. Now, the thing is that the cloth masks, honestly speaking, have zero protection completely. So the thing is that it's a different thing that people on the roads are wearing cloth masks and all that. So if you're just generally out and all that, you wear a cloth mask, it's fine. But if you're going to be in the hospital, then the patient, to protect himself also, should be given definitely a triple layer surgical mask. So basically the patients and all of them wear a triple layer surgical mask. But every person who is actively involved in patient care and is going to be coming in contact with the patient in less than 3 feet distance should definitely be wearing an N95 mask.
Right. I think that is very, very important message, particularly for healthcare workers. And in fact, in my clinic, we tend to distribute masks. A 3-ply surgical mask is surely given to all those guys who don't have a mask with them to carry around, and that is bare minimum that they need to have. Dr. Ramchandra, yes, please, your word on that, sir.
Amita, may I just interject? I'm given to understand that the N95 is a valved or a valveless one. The one with the valve supposedly says that I protect me, myself, but I infect you.
Yes.
How much truth is there in that?
You're very, very right, Ram. Excellent question. So actually the thing is that N95 has a very good fit. And what happens is that it does not allow much of air entry. That is how it's giving us protection from the virus by 99%. So actually what happens is when we are wearing N95 mask, the amount of the air that we are breathing has more carbon dioxide. So basically you are breathing in air which contains more carbon dioxide, and therefore healthcare workers who wear it for a long time, they start getting a headache, they start sweating, they feel more weak. Some people kind of even pass out. So there is N95 with expiratory valve, which is mainly for industrial areas. So people who work in occupational areas where there's exposure to fumes, gases, etc. There's an expiratory valve whereby what you are exhaling, the valve will allow you to exhale out, and therefore what you are inhaling is containing less carbon dioxide. So what was applicable to occupational industry cannot be applied in today's day and age, because when I wear an expiratory valve, if I'm infected, I'm merely infecting somebody who's close to me. So I'm not getting infected, but in effect, I'm infecting the other person. And healthcare workers very well could be asymptomatic carriers. In fact, we have a higher chance of being asymptomatic carriers. So honestly speaking, it would be better to avoid expiratory valves unless you are into a very demanding situation, like maybe operating, which is going to be a very long surgery, and your ability to operate is going to probably go down because you're going to be, but it doesn't happen. We are doing 6 to 8 hours ICU duties at a stretch wearing N95. We are doing quite well.
Right. Dr. Chetan. Yes, Dr. Chetan, please. Dr. Chetan, come in, please.
Yeah, I just want to ask Dr. Amita another question, that versus N95 versus wearing a double surgical mask for all the healthcare personnel. Is that feasible, comparable, or one has to have an N95 for all the healthcare workers, as you said?
So honestly speaking, N95 definitely. So, while we had the lockdown and when we kept on saying we have to prepare ourselves, the first thing we had to prepare ourselves about was to, produce the N95 mask. Because only thing that protects us is N95 mask, and actually even surgical mask gives you protection of 70%. So that's not a good protection at all. And by wearing
if I wear 2 surgical masks, so
coming to that. So there are trials that one
available in any hospital, right, or even in a clinic.
Absolutely right. So I'm just coming to that. So there are trials which have proven that one surgical mask gives you 70% protection. Now the thing is that by wearing 2 surgical masks, we may psychologically feel better protected, but there is no trial which says that it protects you anymore, So then why wear 2? You might as well wear 5, So the thing is that N95 is something that you have to anyhow procure for everybody who is a part of your healthcare system. And now N95 is available everywhere, good quality, which is also recommended by the government. All those who don't have resources, please message me. I'll give you addresses, but please do not compromise on N95 masks.
Dr. Ramchandra, quick comment on that and we move on to another important aspect.
The N95 is a very important point of discussion. So I want 2 questions to be answered. One, can the N95 be reused? Ideally, no, but in our scenario, we are. So if we are, there's an AIMS guideline. Could you elaborate on how we can reuse it? How we need to protect it? Should we keep it in plastic boxes? Should we keep it in paper? Should we dry it? Should we put it in a cooker? These are questions.
Okay, so excellent question. So the thing is that as Dr. Ram said, ideally you don't want to use it, because as you use it more and more, the filter loses its efficacy. So under best situations, don't reuse. And honestly speaking, now N95 masks are freely available. So I don't see any reason why we want to reuse unless we want to save money. I'm again repeating, currently N95 is freely available everywhere. So whoever's talking currently about reusing N95 mask is only trying to save money. Please don't do that. You know, the thing is that if you have money to buy a new N95 for yourself, you better have and spend money for the rest of your staff also, because if that staff gets infected, they'll infect us also. Over and above, if we're in a situation where we need to reuse N95 mask, then there are a number of ways of doing it. So either you keep it in the same bag in which you get your N95 mask, you know, you open it in a nice way, and you basically keep it in. After you finish using it, you put it back over here, or you put it into paper bags. And the thing is that you have to wait for 120 hours. So if I wore it today for 6 to 8 hours, I have to wait it for 5 days, and then only I wear it again. So you have to have 5 masks. Number is 1, 2, 3, 4, 5. You wear the first mask, put it in the bag number 1. You remove the second mask, wear it, put it in bag number 2. So like that, after 5 days, you use it. And each mask can be worn 5 times. After you use each 5 masks, you have to chuck it for sure. So you can do that.
Right.
Yes. Then there is.
I think this is something very important, and one another very important aspect that we need to understand is how to wear it. There is a press fit to prevent a leak of the air, and that is something that we all must remember, that there is a particular way to wear it to make it really efficacious, and we all must follow that. Coming to very important aspect, Dr. Shushruth, Dr. Babulkar, hand hygiene. I mean, you know, even outside my clinic, my own staff, when we were doing this induction, I asked them to do a hand wash, despite having demonstrated them how to do it. 90% of them, for more than 3 continuous occasions, either didn't do it properly, or they were really not doing it for the appropriate period of time. Can you please highlight on the role of hand hygiene and how it should be done, for how long it should be done? Dr. Shushruth Babulkar, please. Dr. Shushruth, you will have to unmute yourself.
Yeah, so there is a debate on how to effectively take care of hand hygiene. Two issues. One is visiting patients and our frontline health workers, which includes nursing staff and reception area workers as well. So of course, reception area workers and nursing staff, they know how to take care of the hand hygiene, and they do it effectively. But visiting patients is a big problem. So at my place, as I suggested, at barrier 1, we have screening for their thermal screening. They have to make an entry. They pass that barrier, and barrier 2 is their automatic sanitizer, which gives an effective droplet. So there are usually 4 to 5 droplets which will spread, and right on top of that sanitizer, we have one illustration which suggests how to go about and take care of all areas of the hand and how many minutes they should be doing it. Of course, saying all that, as you rightly suggested, there will be a lot of people, visitors, who would skip this process and try to jump in terms of using adequate this thing. Plus, if the sanitizer doesn't drop the droplets, they would still want to skip that step and go ahead. So there has to be one person who would make sure that the sanitizer is delivering adequate amount of sanitizer. So there is a beep which comes out, not only the light but the beep also. So that's one modification which we have done for our place. So light as well as the beep goes on, which depicts adequate amount of sanitizer being poured on one's hand. And of course, that guard is looking at that person, if that person has done 1.5 or 2 minutes of this thing.
I think thank you, Shushruth, for bringing out the highlights of the most important parameters. I'll come back to Dr. Amita. The most important parameters of safety are hand hygiene. Remember, there is a tendency for every human being to touch the face at least 2 to 3 times per minute. That counts to 3 to 5,000 per day. And this is something that you all must avoid. There should be a temptation to not touch your face and keep your hands away as far as possible. After you have touched any surface, you have seen every patient try to sanitize your hand, and there is a particular way of doing it between the fingers, back of the fingers, the thumb, the wrist, and it should be done for minimum 30 seconds, not less than that, and that is bare minimum. The mask care is also very important, and whenever you're using face shields and goggles, ensure that when you are removing them, you're not touched it, and if you have touched it by any mistake, please remember that hand wash is the only way out to keep yourself safe. Dr. Amita, your concluding remarks on that.
Something very, very important. Actually, the thing is that we must insist that the payment hopefully is done, either they do it electronically, or if not possible, then by credit card, because it's easy to desanitize a credit card. If at all the patients are going to give you notes, this is very, very important, because notes are also a source of spreading infection, which we don't realize. So you don't want to touch notes. So basically you should actually have a drawer, and you should tell the patient to put the money over there. So you have to tell they have to get the correct change. They have to show you the money, and they put it over there, and you're supposed to touch the money only after 4 full days, because the virus is known to be on paper for 4 full days. And this
Yes,
is
I think plastic bags where money can be collected, and Dr. Chetan will be collecting his money, and I will really find out where he's keeping his money, where I can snatch away from him. Dr. Chetan, your word on that.
Yeah, there was in between a suggestion that you keep 2 boxes. One is to give the whatever has to be given back. One is to collect the money, and both the boxes should contain formalin tablets. Any rollover on this formalin tablets, Amita?
So honestly speaking, what we are actually doing is that we are telling when appointments are being given, they are requested to do online payment.
Yeah, that's fine. That's fine. For those who can and will do, that's not a question. But some who will keep cash.
So, okay, so the thing is, whoever wants to pay the cash, they are told that this is going to be the amount, get the correct amount. And the thing is that the money, there's only one drawer, and the money is put over there, and then you actually lock the drawer and you open it 4 days later. That is what is being done.
I think I'll move in forward from here. Again, saying that the guys in villages do not know what Paytm is, PayPal is absolutely not a truthful thing. I know of sabji walas who have Paytm with them. I know of guys who buy alcohol, do payments with Paytm. And so we all have to embrace our future. And if it has not happened till today, we can start educating it. And somewhere the change has to start. And I hope that we will be the drivers of this change in future for all our patients who are even not educated till today. Probably this will be the beginning of digital payment modes in our country. So moving ahead, we are now in an era where patients have been seen in consulting. We have done all the basic work in the consulting area. We have followed the protocols. And now is the time when a patient actually requires a surgery. And with a disclaimer that emergency surgeries will continue to be done in the same manners, however, with an added clause of safety in there. My question here to all our panelists is, should we be redefining the indications for surgery? For example, a Colles fracture, clavicle fracture, tibia fracture, or humerus fracture can be managed in multiple ways. Shall we be choosing and not operating upon these patients even when the dire need comes across? Let me just start my word with Dr. Karne. Dr. Karne, would you be following the standard indications of surgery since we all know the safety precautions now, or you would want to redefine the surgical indications in your practice now? Dr. Karne.
Unmute me. Yeah.
Yes, sir.
Well, of course, we have to follow the precautions or other indications for surgery, that as far as possible, surgery should be avoided. That is the first thing. The days of the Sarmiento and the, Charlie will come back again, that how to treat the patient conservatively as much as possible, including the spine and the other patients. And second thing, if at all the surgery is a mandatory one, then we have to take all the precautions, right from the legal precautions, from the consent to the operation theater as well as in the wards. So we have to avoid the elective surgery as far as possible, at least till the peak goes down.
Right. Chetan, how would you plan to redefine? Remember, we are talking about guys sitting in the most peripheral areas in Solapur, Kolhapur, in a small nursing home where a patient sees a Colles fracture or a clavicle fracture, which generally would require a surgery in their routine practice. This is the time we should redefine it.
So I would, do a lot of risk stratification here. When dealing with elective surgeries, I would try and avoid what I can avoid in terms of, say, a clavicle fracture or an undisplaced tibia or many other fractures which could be conserved without an unfavorable outcome. I would treat conservatively. But having said that, in today's world, I would not really compromise on my indications for surgery. I would rather do risk stratification, and I would avoid surgery in those patients for example, geriatric patients, a lot of comorbids, etc., telling them that this cannot be done. I'm talking only of elective cases here. This cannot be done, or you stand a higher risk of catching the infection or even mortality and morbidity. And with that risk stratification in place, the rest of the cases, I would go ahead and operate with all the prerequisite precautions.
Dr. Trika, your OPD is starting on Monday, and Monday, the very first day, you see a patient who's got diabetes, blood pressure with a neck femur fracture. How are you going to redefine your indications, and how will you alter your surgical management in these patients? Remember, we are already told that we are dealing with a semi-elective situation in an elderly patient. Would you not operate in these patients, or something that you would do it?
For us, hip fractures are an emergency, so we always treat them. Even now, over the last 2 months, we have been treating. The majority of fractures which I have been treating over the last 2 months have been intertrochanterics and neck femurs in an elderly patient whom we had to operate, and we were operating without any, I would say, we had to do that, and we have done that without any qualms.
Right.
Regarding the other things, regarding the distal radius and other things, it's the way you look at it. Previously also, I could say that being in a government, though a premier institute, I have had the luxury as well as the good fortune, I would say, of having an experience of non-operative treatment in many of the cases. And that's why I am confident of treating them to the same functional ability as I would do. And I will always check according to the fracture pattern and do the risk stratification based on the fracture rather than on anything else. But non-operative treatment has certainly jumped up its pace and has gone very high up in the priority list as where decision making is concerned. We are not in today's world, my dear Chetan. We have already gone back 100 years back. Who had ever in his lifetime got a lockdown of 2 months altogether sitting at home and doing nothing? So it's nothing. Amita said, we have changed our pattern. We have to go slow. We have to understand less safety.
Dr. Ram, let me catch you there. Now, how has your stratification changed? On one hand, Dr. Chetan mentioned that, yes, indications may not change, but risk stratification will become even more aggressive. And I think this is something that is an opportune measure to make our surgeries more safe. Dr. Trika mentioned the importance of being little slow and less aggressive and being more conservative in managing these patients. Let me put a case scenario to you. A patient with crippling radiculopathy not getting better with conservative treatment. How would you manage that patient in current scenario?
With crippling radiculopathy not responding to non-surgical care, the first thing is I want to know whether he's a 25-year-old fit guy or whether he's a 65-year-old unfit guy. That's going to make a major difference as far as my threshold is concerned. Now, if he is a young, fit guy and I still cannot salvage him, I would give him the option first of taking a nerve root block and probably holding on, which will be less invasive than my surgical disposition. I would not offer him surgical intervention. I would give him all the non-surgical modalities as far as possible. In the elderly, let me be very frank, my threshold would be even higher in the sense that I would try to sort of deny them surgery as far as possible, clearly knowing that yes, it can be very, very painful, disabling, may give them a disabling limb neurology to a certain extent, but may not be threatening their life if I don't operate on them. I have to balance that very, very clearly. So there has to be a life versus limb balance that I have to look at.
I think this balance is something that we all may have to play more and more upon. Dr. Shinde, your word on that. You have a neck femur fracture in a middle-aged elderly guy. Would you depend on osteosynthesis, or this is the time you want to depend on bipolar once and for all? Dr. Shinde, I am putting you in a catch-3 situation. What will you do from here?
I am commenting on the same. It depends upon the patient, hospital setup, and surgeon skill. The indications are going to be changed. As far as possible, avoid surgery if the results are not going to be compromised. Results are same with the conservative treatment as well as surgical treatment. As far as possible, prepare the biological fixation and avoid the complication. Similarly, if patient is having additional comorbidities, why you are taking risk, or old age patient?
Dr. Shushruth, I know You have worked with the mentor and mentor of mentors. You're the son of the legend in orthopedics, and you know the exact art of FCB also, functional cast bracing. You know the art of plating also. You know the art of MIPO also in an intra-articular tibial fracture. At this point, a month ago, you would have done plating. What would you do now? Would you redefine and refine, or you will continue doing surgeries when there are intra-articular fractures in joint around?
So what am I doing now? What I'm doing now is I'm just buying out time till definitively some solution to this comes up, which I hope in another 2 weeks time will come up. Why I'm saying that is, no way your offer of the treatment should compromise the long-term outcome, especially of the joint. So intra-articular, something like spanning fixator, wait boss, let's meet after 2 weeks time, which I'm doing. So there is a patient who has a completely exploded distal radius. I put a fixator there. I know I'm going to need not only one side plating, but two side multiple plating. So that guy is waiting since last 3 weeks. I know my fixator is giving him ligamented access and working out around the wrist. If at the end of 1 month, nothing happens, he's still not a loser because that's an accepted way of management.
I think Shushruth, you have made the point, guys. What message Dr. Shushruth has passed on is the message that we should drive home from here. What used to work till today may not work from here. What was your habit should not become a habit for the future. This is the time when we will want to become more thoughtful. We will want to become a little more brainy rather than being the carpenters of the bones and joints around. This is the time we may have to redefine the indications. We will have to refine the management options for the same problem that otherwise had a very straightforward surgical solution. Now is the time to be thoughtful about it, and we will have to really think more and more often about it. Dr. Furness, you just mentioned about the complication rates driving high up in patients who are operated now. Do you think that the same logic applies when a patient has been tested, risk stratification has been done, and is an asymptomatic patient on the day of surgery? Do you still feel the complications are going to be high up in these patients?
See, what is happening right now is so to answer your question, if the patient is coming as a COVID positive, at the moment, what is happening in our center is that we are referring it to a COVID designated COVID center.
I think
And
Ashish, I think this message, I would want to drive it absolutely loud and clear. Dr. Amita has mentioned time and again, this is the echo of the panelists. Any patient who's symptomatic or has COVID positive test done, please do not operate on these patients. The mortality rates, the complication rates are really high. It is only for negative asymptomatic patients this whole debate is going on, whether you should start jumping into elective cases or not. But for COVID positive patients, symptomatic patient surgery is strictly not recommended. Ashish, next statement, please.
Sorry, so if the patient comes COVID positive, so what is happening right now is that the surgeons are actually waiting for the test to come negative. And here we are talking about only fracture neck femurs, because those are the only surgeries apart from infection and tumors, which are the common ones. You know, as the shoulder fractures, elbow fractures, everything is being conserved in the community.
Right.
So the risk of death in these subsets. Yes. One more thing I'll just like to highlight is all these papers from Wuhan, Spain, and Italy which have come up is that the mean age of those patients have all been upwards of 84, 85. They've all been fracture neck femurs who have had an increased risk of mortality. In some of the papers, in fact, the patients who were operated had a slightly lesser risk of mortality as compared to the patients who never came on the operating table. So those patients were too sick anyways to undergo surgery who succumbed. So yes, I agree.
Amita, this brings me to another point Dr. Shushruth highlighted and Dr. Chetan echoed upon, risk stratification. Do you feel that in current scenario, there is something like a step up in risk stratification also for all the patients as a blanket thing that we can do? And if yes, what is that additional risk stratification that we should do in pre-operative state when patient is seen in consulting and is planning for a surgery? Dr. Amita, unmute.
Yes. Yeah. So actually, I'm going to be covering this in my talk. So do you want me to answer it now, or should I just cover it in my talk?
Can. Yes, please, if you can.
Okay, so I basically feel that, in COVID, we have this something known as happy hypoxia. So the patient is hypoxic, but he never feels breathless. And we have people who are absolutely normal, and we just check their saturation. It turns out to be 85 or 87. So I basically want to say that though you all are surgeons, whenever you see a patient, please make sure you have a pulse oximeter. If the patient's saturation is 95 or less, please do consider that he could be having COVID. And please, I mean, if he doesn't have any underlying cardiorespiratory embarrassment, and if his saturation is 95 or less, please keep on asking him again and again and again, because he could be possibly having COVID. So this saturation checking is very important. And whichever patient you're operating, even if you're sure it's not COVID, if you don't have a good ICU setup, please do not do elective surgeries, not even emergency surgeries, because actually we found that surgery unmasks underlying COVID. So
Right.
whatever reports we were talking
So,
about,
Amita, do you mean to say that these problems would come to a surgeon only when they are doing a general anesthesia wise surgery, or even regional anesthesia surgeries would give similar state of complications?
so basically it's a general anesthesia which is going to give the complications, not regional anesthesia. But the thing is that general anesthesia is something
Right.
basically masks, I mean, it increases the inflammation and the entire cascade starts. So that is the thing.
So would you recommend that all the surgeons, whoever are doing, like there is already an upsurge in regional anesthesia happening, would you recommend that whenever possible, try and use regional anesthesia if you're doing even an emergency surgery like hip or knee fractures?
Okay, so what I would basically say is that if it's an emergency surgery, you decide what is the best for the patient, because you emergency surgery. So I would believe in ortho, it's polytrauma or it's cauda equina or something. So you basically decide an emergency what is safe for the patient and do it. If it's kind of an urgent semi-elective surgery, if you can do it as well under a regional anesthesia, I would say it's much better in today's day and age, provided patient
Right.
this thing is not compromised.
Right. I think this sums it up, all this session of the indications of surgery. There is a big list of indications of surgery. What is emergency? What is semi-emergency? What is urgency? And it has been released by IOA and MOA both. There are guidelines laid down by Dr. Shushruth and Dr. Chetan under the aegis of MOA by Dr. Karne and Dr. Ajit Shinde's guidance. And there are already a list of indications how to refine and redefine. There is a wide variety of consent available. However, it has been said that every patient and attendant involved in healthcare should be made to understand not only the extra care and extra expenditure that is going to come across, but also the risk of COVID-19 exposure during treatment, and also higher chances of problem that can happen. Some surgical guidelines that have come across is use of minimal invasive spine surgery, use less invasive options, use regional anesthesia, try to use transparent dressings like Dr. Trika just highlighted upon, try to have less contact with these patients, try to have follow-up in such a manner that patients do not have to have physically present with you. And risk stratification, or when will patient deteriorate, is something that we all need to be very aggressively evaluating from here on. And like Dr. Amita mentioned, that pulse ox is one subtle thing that we can do in our clinic setting also to understand if the patient is in happy hypoxia. And now the most important part of risk mitigation, which is pre-operative workup. What is foolproof? Who other than Dr. Amita Nene to tell us about what is foolproof and what investigation should we do in patients? Mind you, in asymptomatic patients requiring elective surgery, what is the foolproof investigation that we need to do? And Dr. Amita, over to you from here.
Yes,
So
thank you
Dr.
very much.
Amita pulls up her slides on for us. May I ask? Yes, Dr. Amita, you're saying something.
Yeah, no, nothing. Thank you very much. I'll just load my, just a minute.
Dr. Shushruth, what is the protocol of investigations like while the slides come up? So what investigation do you do routinely, since you say that there are not aggressive testing in Nagpur?
Somehow I'm not able to see you guys. Huh? Now I got you again.
Yeah.
Okay. Sorry, go again. What was the question, please?
So what are the list of investigations that you have been doing in your institute before taking up any patient for surgery, be it emergency or elective?
Speaking, I leave it to my chest physician friend to decide, number one, whether that patient is, because we are talking only of chest and respiration being the main area which gets hit by corona. But now we have also found that it's also the CVS, the cardiac system. So it is for me to decide only the age criteria and the comorbidity which is associated. Then I decide, let my intensivist and my anesthetist decide whether that patient is going to be able to pull through that emergency surgery. So the only criteria which I decide is the age of the patient and.
Right. Dr. Trika, before Dr. Amita starts her talk, can you please elaborate on AIMS investigation protocols for pre-operative risk stratification? What are the investigations that you mandatorily do in every patient before taking the patient into OT?
In the COVID times?
Yes, now, right? Like tomorrow if you have to see a patient
I would
and
say, okay, so it will be totally different from what is happening in the private hospitals. As per the ICMR guidelines, till date, they haven't said that the pre-operative patients, everybody has to be tested. If I can say that, every person, if you want to test for COVID, has to be taken and seen by an infectious disease person. And only when he says and finds there are still very less number of indications for doing pre-op testing of COVID. So for me, COVID tests are not done if a patient is taken up for emergency, if he does not fall into the top 8 points. Yes, 2 days back also, the ICMR has given the guidelines and slightly changed them, but 2 to 6 points, if he is not falling in, no COVID test will be done. Now we are planning with the things to go get in the COVID test done now, pre-operatively for all the patients. But till now, we were getting all the routine tests, definitely a chest X-ray, and looking after if we have to go for general anesthesia. General anesthesia was avoided as much as possible, and all the surgeries, if possible, were done under regional. There was no specific test we were doing like D-dimer or lymphopenia or looking at other things. Routine test for emergency.
Right. So Ashish, any inputs on that? I mean, there is so much of play around happening where we are asked to do COVID test on one day, we are asked to not do COVID test on another day, HRCTs on the other day, then D-dimers. What is your take on that? When you see a patient, what are you going to recommend from here on?
So we used to follow the ICMR guidelines, as Dr. Trika said, and we were not screening our patients till the first week of May, when all the surgeons came together and they were afraid and they were insisting on a HRCT and a swab, which probably did not have much of a yield, because even we audited our own HRCTs and the swabs, it was had no yield. So at the moment we are following the ICMR guidelines. And being a private hospital, yes, some of the surgeons are doing the COVID test before admission.
Right. Dr. Amita, there is a question from the delegates. I'll just try to highlight you. We are having 3,000 plus viewers at this point listening to all of us, and they will be following all what we speak here. So one-liner question, like a full toss ball for you, either a 6 or a bold out here. COVID test in an asymptomatic orthopedic patient, yes or no? We know that there are false negatives, but yes or no, and dependability on that test.
If you're planning surgery, definitely a yes. Yes.
And dependability on it based on safety criteria.
20%. So always take the patient as asymptomatic carrier regardless of the result. So
right. I think that serves the answer.
Otherwise.
Yes. There are lot many such questions here, guys. We know that the tests that are supposed to be done, mind you, on one hand, when we are talking about pre-operative risk mitigation, we are not prompting you to go ahead from tomorrow, do these tests and start your routine surgeries. Remember, it is risk stratification that is very important in these COVID times. We would surely want to redefine our indications and refine the surgical management options based on the guidelines that we have here. And who else to tell us about the guidelines to follow? Dr. Amita Nene will be telling us about pre-operative workup and also what is the bare minimum PPE standardization for all our healthcare workers. Dr. Amita, over to you.
Thank you very much, dear Ram and dear Vishal, for organizing this wonderful webinar. Thank you very much, all the panelists with me and the lovely audience. So I want to basically start my talk by stating the obvious. We know that COVID-19 has been the biggest catastrophe of our times. Before I start giving my talk, I just want the audience to understand one thing. You all need to imbibe this, that a mindset change for every doctor today is mandatory. We have to understand and realize that it is not the same anymore. We just need to slow down. We need to realize that precautions are more important than numbers and the returns are going to be low. Please accept it. You know, the famous English proverb, a stitch in time saves 9, was never more applicable before as it is in today's COVID times. So when I talk about mindset for change for doctors needs to happen, it needs to begin from us. We need to evaluate our own risk factors. And after evaluating our own risk factors, we need to make an informed decision as to whether we want to work for next few months or we don't want to work. This becomes even more important for all of us who are 60 years or more of age, or any of us who have blood pressure, diabetes, underlying cardiac, pulmonary, or renal conditions, are on steroids or on some immunosuppressive therapy. So if we have any of these comorbidities, please think back, take a deep breath, and decide, is it really worth practicing? Because these times will definitely pass away. If we just have to wait it out, 3 months, 4 months, we will definitely be out of it. So please decide sensibly first, should you be working or not? Assuming we have taken a good decision and we've decided to work, let's come to how we want to go about when we have a patient who requires an elective orthopedic surgery. So when we say the patient is asymptomatic, we need to first of all know what are the symptoms of corona. So we all know that a COVID patient has fever, may have cough, may have sore throat, running nose, breathlessness. So probably we think these are the only symptoms of COVID. But what we need to know is that COVID is a very difficult condition, and very often patients present with completely different symptoms which can actually confuse us. So we have to ask the patient, is there any fatigue? Because 70% of patients complain only of fatigue, and 40% present only with anorexia, and 35% present only with myalgia. A very important symptom we have to ask every patient is any loss of smell or loss of taste? Because these are symptoms which come on much earlier, even before the fever comes. And these, very often we've diagnosed patients to be having COVID based only on these symptoms. A lot of patients complain only of headache. Some people have only GI presentation like nausea, vomiting, loose motions, or abdominal pain. And a lot of patients have only skin presentations. They come with urticaria or with reddish purple nodules. So the thing is that you have to make sure that you please take a picture of this slide if you want, and you have to ask your patient about each of these things, because patient may not even report. So ask of each of these things, and only when these things are absent do you want to call him an asymptomatic carrier. Even if one thing is positive, please think that this patient is symptomatic. Also, what is really important in history is that these symptoms are not important only in the patient, but anybody in the patient's family who lives in the same house. If they have any history, any of these symptoms, including the family members, the caretakers, the servants, if anybody in the house has any of these history, then our patient becomes like an alarmingly high risk patient. Also, we have to find out if the patient was really staying at home or he was freely moving around. And if he was freely moving around, then was he really wearing a mask? Was he really maintaining social distancing? And was he practicing hand hygiene? Others at home also, were they really remaining inside? And if they were going outside, were they maintaining social distancing? Were they really washing hands? Were they really? This becomes very, very important. And based on this history, so presence of symptoms in the patient or anybody in the same house, whether the patient was going out or not, or anybody in the house was going out or not, and maintaining the basic hygienic measures. Based on this, we decide if the patient really has a chance of being an asymptomatic carrier or not. And based on this history, we want to label our patient as high risk asymptomatic carrier, where he has been going out, not taking precautions, or somebody in the family is unwell, or somebody in the family has been going out all the time and also coming in touch with the patient. Or we will categorize him as a low risk asymptomatic carrier if all the above are absent. But the bottom line is that the patient remains asymptomatic carrier definitely. So while we are taking the history and examination, as I said earlier, checking saturation of every patient is extremely important, because in COVID, there's happy hypoxia. We have patients with saturation of 80% who are very happy, not complaining of breathlessness, and they don't even look breathless. So if the patient does not have underlying cardiopulmonary conditions, and if the patient's saturation is 95 or less, you want to basically consider that this patient could be having COVID, and you want to investigate him accordingly. So what investigations do we want to do? So we have so many tests that we kind of keep on hearing about. So we have the RT-PCR, which has been the gold standard till date. We have the TrueNat now. We have the Gene Expert. We have the famous rapid antibody blood test. We have the HRCT chest. And of course, we have all the blood investigations. So let's go through these tests one by one. So basically the thing is that we know that we need to take a swab. So do we take an oropharyngeal swab or do we take a nasopharyngeal swab? So we take only one swab. No, this is not true at all. We have to take both. Nasopharyngeal as well as oropharyngeal swab in every patient is a must. So nasopharyngeal swab has a sensitivity to pick up COVID up to 63 to 73%, whereas oropharyngeal swab has a sensitivity of only 32 to 60%. If both are taken together, then sensitivity increases to 75 to 80%. ICMR also recommends that it has to be oropharyngeal and nasopharyngeal swab, but unfortunately, even today, a lot of places are doing only oropharyngeal swab whose sensitivity is as less as 30%. So even before you advise the RT-PCR testing, you have to tell the patient that make sure nasopharyngeal and oropharyngeal, both the swabs are taken. And for some reason, if only one swab is taken, the patient is supposed to point out and insist that the other swab is taken also. Also, the correct technique of swab collection is extremely important, and this patient has to be informed about from before. Basically, what happens is that the person who's collecting the swab is also scared of being infected, and therefore very often they don't end up collecting a good swab. So whenever it's going to be a nasopharyngeal swab, they are supposed to actually go inside, they are supposed to twist the swab. It actually touches a tympanic membrane. It is so painful that it elicits a tear. So we have to basically tell the patient that if the swab is collected correctly, there should be a tear coming into your eye. And when the oropharyngeal swab is taken correctly, the patient has to gag and the patient has to cough. So patient has to be told from before that you have to have a tear in your eye and you have to cough. And if these two things are not done, please insist that the technician takes the swab again. So it is basically, instead of telling the technician to do the correct thing, if you tell the patient what to expect, then there's a better chance of the swab being collected correctly. So does negative nasopharyngeal and oropharyngeal swab rule out COVID? No. So basically we know that the sensitivity of the RT-PCR is like about 75 to 80% at the most if both the swabs are taken correctly, and that too they are taken in the best possible way. False negative swab results are seen when the viral load is low, that is you check the patient either too early or either too late, or if the sampling technique is improper like I described right now, or the transportation process is not correct, and importantly, if there's limited gene detection. So for the swab report to come, for the RT-PCR to be reported as positive, you require 2 genes. So if the patient has only 1 gene, then the patient will be called negative. So there are 30% chances where patient actually has COVID, but the RT-PCR comes falsely negative. So if there is a high risk, if the patient is in a high risk asymptomatic carrier, or if you think that you can probably wait for the surgery for a few days, then it would be good to repeat a swab after 24 to 72 hours while the patient is quarantined, not allowed to pick up a new infection, and then subject the patient to surgery. Also, it's very, very important to give a disclaimer about the negative swab test to the patient. And we have to tell the patient that a negative test does not rule out COVID. A patient who has an initial negative test, this test can become positive after a few days because the patient was having COVID, but earlier the viral load was too low to pick it up. Also, we have to tell the patient from before that the patient has a full chance of picking up infection from our hospital, from our nursing home, from any of us. And therefore, the patient cannot be holding us responsible for this. And the thing is, right now it's Pandemic Act, but despite that, it's always very, very important that we explain this 3 points to the patient, and we also take it in writing, because we don't want patient to unnecessarily trouble us later and increase our stresses, because we have enough stresses right now anyways. So disclaimer about a negative swab test, and also to warn that they may catch infection from us, is very, very important. So RT-PCR was something that we had all the time. So this test takes about 4.5 hours to be reported. And usually most of the labs are kind of running 2 batches. So usually you get the report in 18 to 24 hours. Now, as against that, we have a new test, which is the TrueNat testing. So this is now available. It was available since last 1 month, but at that time the test was primitive, but now we have an improved version and it's a very, very good test. So this is again an RT-PCR test like the conventional RT-PCR test that we've been doing. And the best thing is that this is produced by an Indian company, which is located in Bangalore. It is a handheld battery operated portable machine. So basically this has 2 steps. So you do step 1, and if the step 1 shows negative, then COVID is ruled out. But if the step 1 comes positive, then you subject the patient to step 2 test, which is the confirmatory test. So if the confirmatory test comes positive, this patient has COVID. You do not need to repeat the standard RT-PCR test to confirm. And if it comes negative, then it is not COVID. So step 1 takes 1 hour. If there is no COVID, then patient does not have COVID. If it comes positive, then do step 2. That also takes 1 more hour. So in 2 hours, you come to know as to whether patient is negative or positive. So honestly speaking, I would still say that RT-PCR is still better. But the thing is that that's because RT-PCR can detect 3 genes, whereas TrueNAT detects 2 genes. But if it's a surgery where you don't have, it's an emergency surgery, you can't wait for, like, if the batch is over and you have to wait for the next day for the batch, then TrueNAT can be used for those emergency surgeries where in 2 hours you'll know whether COVID is there or not, because the reliability rate is the same. As against TrueNAT, we also have Gene Expert for COVID-19. So this Gene Expert is the same Gene Expert that we are so used to using for TB. It's basically the same Gene Expert machine that we use, in which in the same cartridge we are putting up the viral samples now. So the advantage of Gene Expert is that 4 samples can be tested at the same time. And so the thing is, in a day, you can test about 100 samples, as against TrueNAT, in which only 1 sample can be tested at one time. The results are available in 45 minutes. So if it's negative, it's negative. If it's positive, in 45 minutes that the patient is positive. The only problem is that these kits are not produced in India. So US provides these kits to us, and unfortunately US has given very limited kits to us. So we don't have too many of us, too many kits, but these kits are available. So what I basically want to say is that RT-PCR, there are 3 types. The conventional is what we have been using, which is 4.5 hours. So if you have the time, then please do that only. But if it's really urgent, then Gene Expert gives you the answer in 45 minutes. If you don't have Gene Expert kits, then you can go by TrueNAT, which will give you the answer if negative in 1 hour, and if positive, then in 2 hours. So this could be of use in these emergency orthopedic surgeries. But if it's not that urgent, please, conventional RT-PCR would be the best. We keep on talking about the rapid antibody blood test, which about 1 month back was just so popular. So as we know, as the name suggests, the rapid antibody tests are actually blood tests, and it detects presence of IgG and IgM antibodies in the patient's blood. So basically, if the test comes positive, that means the patient has either IgG or IgM, or both IgG, IgM against COVID. So if it's positive, then the patient has either present infection or past infection. IgM becomes positive after 7th day of getting infection and remains positive for 21 days. IgG becomes positive from 10 to 14 days of catching infection. And therefore, if the patient is in the first 7 days of infection, this test can come falsely negative. Also, the kits that were bought from China were of very poor quality, and we are not really happy. So currently, ICMR has recommended that the rapid antibody tests are only for epidemiological studies and surveillance purposes, and only to be used in the red zone hotspot areas. They could only be used in those patients who have influenza-like symptoms for at least 7 days. And therefore, the rapid antibody tests currently have absolutely no role to play in asymptomatic orthopedic patients, at least currently, as of now. Don't even consider doing them. HRCT chest is something very popular and very, very controversial also. So the question is, do we do HRCT chest in every patient who undergoes surgery or not? So over here, I'd just like to give a few facts, and then each of you all can take your decisions. So basically, the thing is that the American College of Radiology and both the 2 Indian radiological bodies, the ICRI and IRIA, both do not advocate the use of CT chest for screening or diagnosis of COVID. Basically, the reason for this is the logistic and the safety issue. And this is because it's very difficult to sterilize the entire CT apparatus. So the thing is that if a COVID positive patient goes over there, it's difficult and very time consuming to sterilize the machine and disinfect the room. And we don't have facilities as of now where there'll be 2 CT scan machines where non-COVID goes to one area and the COVID goes to another area. So the thing is, Therefore, routinely, it is not advocated to diagnose or rule out COVID. And if at all you do CT scan, then you have to minimum wait for 1 hour and ideally wait for at least 2 hours while the disinfection takes place. And the next patient can be taken in so that the next patient does not catch infection if the first patient was an asymptomatic carrier. So on HRCT, there are lots of very, very typical looking features which have been identified with COVID. So advantages of HRCT chest are that sometimes the patient could be asymptomatic. He could not be having fever, no cough, no breathless, but HRCT could be still abnormal and it could point towards the possibility of patient having possible COVID. So this is basically the advantage of HRCT, but HRCT has limitations also because these HRCT patterns which are suggestive of COVID are not specific for COVID, and many other conditions are also known to give rise to the same appearance, and therefore whoever CT scan is abnormal, clinical radiological correlation involving a pulmonologist, a radiologist is a must before we decide is this really suggestive of COVID or not. Also, what is really more important is that a patient who does not have COVID, rather a patient who has COVID can still have a normal CT chest. So the patient is asymptomatic, the CT chest came normal. It does not rule out COVID. And just because the HRCT is negative and the COVID test is negative, we may feel that the patient is not infected and we may get a false sense of security, and therefore we may compromise on our PPE use. So what is really important is that if you are doing an HRCT, even if HRCT comes normal, please make sure that you take the best precautions and please still treat this patient as an asymptomatic carrier. And this positive normal HRCT chest should not give you a false sense of security. So these are the tests that we we would definitely recommend an RT-PCR. If you have time, do the conventional one. And if you don't have the time, then do either Gene Expert or TrueNat, whatever is available for you. Rapid antibody tests don't have any role, and CT scan is a little controversial. So some of the centers have a rule where it is compulsory, and some centers don't have a rule. So you can do what you want to do, but knowing very well that a positive HRCT does not confirm TB, that does not confirm COVID, and a negative HRCT does not rule out COVID. Okay, so you want to do a surgery and we need to take a risk consent. So what type of consent to take? So we have to basically decide which COVID patients will have worse prognosis. So whether the patient is asymptomatic or symptomatic, in which patient do we need to have a high risk consent, because which of these are likely to have a worse prognosis. So there are certain comorbidities. If the patient has these comorbidities, then even if the patient is an asymptomatic carrier, he has a very high chance of increased mortality and morbidity. So these comorbidities are presence of cardiovascular disease, diabetes, hypertension, chronic lung disease, chronic kidney disease, cancer, BMI of more than 30, and presence of immunosuppressive drugs. So if our patient has any one of these comorbidities, even if the patient is an asymptomatic patient who has negative RT-PCR and no symptoms, and maybe even a negative HRCT, which is normal, if any of these risk factors are present, please still take a high risk consent. Also, whenever you're taking consent of the patient, you need to tell the patient that you not having symptoms and having a normal RT-PCR, a negative RT-PCR and normal CT scan does not rule out COVID. You still have a 30% chance of having COVID. And if you undergo a surgery, you have a high mortality, high morbidity. You have to explain this to the patient, and you have to document on paper that the increased mortality and morbidity has been explained to the patient, and he understands and agrees, and then he is ready for surgery. And this is very, very important, because the patient can actually, despite the pandemic act is going on, the patient can actually sue you if you have not documented or explained to the patient the increased mortality and morbidity in case the patient was an asymptomatic carrier and you were doing an elective surgery. A good thing would be that if you think that surgery is elective and maybe we should do it, please take a second opinion from your colleague who you trust. And if that colleague also really feels that the surgery needs to be done, then only undergo a surgery, at least till we are peaking and till the flattening of the curve really doesn't happen. It's not really worth it. But the RT-PCR swab came positive. So are there any blood parameters which are associated with worse outcome? So yes, so if the patient is asymptomatic, the swab is positive, you have to do the surgery, then please make sure you do every blood test that I'm mentioning about. We have to do a CBC. If the patient has lymphopenia, then the outcome is worse, even if the patient is an asymptomatic carrier. If there are elevated inflammatory markers, especially CRP and ferritin, if the D dimer is raised, if there's elevated INR, if there's high creatinine, high TROP test, if any of these things are positive, then the patient has a very high chance of worse outcome, even if the patient is asymptomatic. And make sure these tests are done. If these tests are positive, again, sit down and reconsider in your mind, really, is the surgery very important, or you can wait for some more time? As I said, it's not only about our protection, it's also protecting the patient. So 3 types of surgeries are something that I would think you all would be dealing with. One is an emergency surgery. In ortho, it would be either a road traffic accident or a polytrauma or an acute cauda equina syndrome. So if it's really urgent, you have only 2 to 3 hours before you decide. You should probably do a TrueNat or gene expert if it's available. And then regardless of the result, you probably may just have to go ahead with the surgery. If the result is positive, then please do the blood markers I spoke to you about. And please take high-risk consent from the patient. If it's an early surgical indication, for example, fracture neck femur, or if it's fracture spine with no neuro compromise as of now, then based on the history of the patient, please consider of the chances whether the patient is a high-risk asymptomatic carrier or a low-risk asymptomatic carrier. So if the patient is a high-risk asymptomatic carrier, that means he has symptoms like maybe abdominal pain or diarrhea, or somebody in the family has these symptoms, or anybody in the family has been going out without taking precautions, then this patient becomes a high-risk asymptomatic carrier. So even if the RT-PCR test is negative, you please keep him in a buffer room. So it could either be an isolated room in the hospital where limited number of staff are allowed to see the patient with full PPE, or it could just be a quarantine in the house where he is allowed to meet only a few selected people with maximum precautions. So keep him in this buffer situation for 5 to 7 days, repeat an RT-PCR, just make sure the symptoms don't come up. And if there are no symptoms after 5 to 7 days, patient has been adequately quarantined to rule out a new infection, and the RT-PCR comes negative, then you can take up this high risk asymptomatic carrier for this early surgical indication. And if the patient was low risk asymptomatic carrier, then you need not have a buffer. And with a negative RT-PCR, you could go ahead with the surgery if it's required. For elective surgery, what we are talking about, I still maintain my first sentence today, what I spoke when the webinar started. Elective surgery, till the lockdown is over, please don't do it. Please wait out for 4 to 6 weeks. It's not really fair and it's not worth it. What should we wear? Very important. So PPE is something which is the only savior that we have today to protect us, believe me. So it is most important to protect men, as Dr. Vishal told us repeatedly. So mouth, nose, eyes are the main areas of entry. In addition, hands also become important area of entry because we are touching our hands to these important organs. And therefore we have to most importantly save our nose, mouth and eyes, and of course hands also. N95 mask is a must for every healthcare worker, and therefore no compromise over here. If possible, please don't even try to reuse them because now the supply is not a problem. So if you're going to be doing an OPD or if you're going to take a normal ward round, then on entering the hospital, please clean your hands, wear a N95 mask and change into hospital scrubs. Over there, wear a gown with full sleeves. You can either wear goggles or eye shield, or I basically prefer a face shield because it covers my neck also. Gloves are a must. I definitely wear a surgical cap, and either you wear shoe covers or you change into hospital shoes. I think it's not really worth wearing the same shoes also, because especially people who have children, toddlers in the house, it could be a risk for them because they're going to be like, crawling on the floor and they just could be putting their hands to their mouth. So it would be better to protect your shoes also. What is important is no watches, no rings, no bracelets. For women orthopedics, pediatricians, no dangling earrings. Keep cell phones, wallets, handbags, etc. packed away before you start your OPD. When you have to do your surgery, you require the protection level 3, the level 3 PPE, which is N95 mask, balaclava, eyewear, goggles, surgical gown, face shield, double gloves. And if you have an N95 mask which is not of the company 3M. 3M is a company which is the best, which gives you 99% protection. If you have any others, we are not really sure how much protection it gives you. In that case, I would recommend, in addition to N95 mask, please wear a surgical mask over it and have a shield over it if you're going to be operating. That would be the best thing. So I've given a lot of information. Let me consolidate everything in the form of take-home messages. With the good history, please confirm if the patient is truly asymptomatic or not. And we have to also check about history of symptoms in those staying in the house, not only in the patient. We have to elicit history about patients staying in the house, whether wearing mask, maintaining social distancing and hand hygiene while going out. Not only the patient, people living in the same house, each of them, family members, and also the domestic health. If the patient is old, IHD, hypertension, diabetes, pre-existing pulmonary, renal, or cardiac conditions, these are risk factors for worse outcome, and therefore avoid elective surgery in these patients. RT-PCR, the conventional one, is the current gold standard for the diagnosis. And in addition, now we have Gene Expert, TrueNat, which are equally good, but they are faster. But still, if you have the time, then RT-PCR, the conventional, remains the best. Both nasal and oropharyngeal swabs are a must. The correct technique is very, very important. Tell this to the patient. It'll be more effective instead of trying to tell this to the technician. Negative swab does not rule out COVID, even if done it in the best possible way. It's only about 70 to 75% and not more. Rapid antibody blood tests have no role in asymptomatic orthopedic patients for elective surgeries. Asymptomatic carriers can somehow have abnormal HRCT chest. However, you require clinico-radiological correlation because the appearances are not really specific for COVID and are shared by many other pulmonary conditions also. Despite a normal HRCT chest, the patient can still be an asymptomatic carrier, and therefore a normal HRCT chest should not give you a false sense of security, and we cannot be compromising on the PPE only because the HRCT chest is normal. We must assume every patient to be COVID positive, regardless of the result of RT-PCR and HRCT chest. We have to protect the nose, mouth, eyes, and also hands. N95 mask is a must for every healthcare worker, whether a doctor or a nurse or a ward boy or a receptionist. And there is no alternative to adequate PPE, and therefore there can be no compromise. To conclude, you all will be remembered as the orthopedicians of the COVID era. So you all should not allow any room for mistakes. Thank you.
Thank you, Dr. Amita. It has been really wonderful to really try and push across the right points at the right time of the session here. We are 2 hours in the session. I think nothing could have made it better to look the session in the more interesting way. Thank you so much again. So we started with a time when we emphasized the need of starting elective work, how to triage our elective work, what amount of elective work we would want to start was emphasized by all our panelists. We then spoke about how to start our consulting. When to start is clear. How to start, what protocols have to be laid down in our consulting rooms, what changes infrastructurally we have to do in our consulting rooms, how to triage and screen patients outside our consulting, how to manage our consulting appointments, and all those points have been very, very clearly mentioned. Following consulting, we also spoke about surgical indications, how to redefine and refine them, the need of proper type of mask and safety in the consulting clinic and also hospital has been emphasized earlier in the seminar here. We then spoke about different kind of surgical management strategies, which will surely require to be more thoughtful, and the previous norms of orthopedics no more apply in the current scenario. And then we spoke about the importance of risk stratification in all patients where you really want to go ahead and do a surgery. And how do we do risk stratification has just been highlighted, the most important aspect of which remains protection of the interest of patient by providing them the emergency care they really need. Keeping this emergency work, you really want to up your game before you really jump into it. And elective work can really hold on unless and until there are features to favor that you will surely be breaking the chain of transmission, keeping the healthcare safe, both for the healthcare workers, the doctors, the surgeons, and also the patient as well, reducing the overall morbidity and mortality. And surely by not contributing to the spread of coronavirus to us, to healthcare workers, and to the patients as well. After you have did a risk stratification, you know that PPE is your savior, and you would want to have all this in your OT. Other than PPE, there are certain OT norms. There are certain anesthesia norms that are really, really important for all the orthopedic surgeons to be followed in the operation theater. Before we go and jump into the details, because the OT, the surgery, and the follow-up part is the part 2 of this COVID with coexistence Ioacon 2 webinar bounce back, which will be coming up in the next week scenario. But before we go to the part 2, may I have Dr. Chetan? Chetan, what are the changes that you recommend in OT? Can you just briefly tell us structural changes in the OT? What all things need to be done by the orthopedicians who is indulging into emergency services in this time?
Okay, so previously it was thought that a negative pressure OT was required, but nowadays it's not the norm. What you require is a positive pressure OT with more than 25 air changes per hour. So you must have a laminar airflow with HEPA filters in your place, and OT where you have more than 20 at least air changes per hour happening. Then most of the cases should be done, if possible, under regional anesthesia. If a general anesthetic is a must, then you should have those intubation chambers, etc. During general anesthesia, only the anesthetist needs to be and the assistant in the OT. And for 15 minutes after the anesthesia, the rest of the team goes in. There should be minimum people, minimum personnel, minimum equipment. The whole bunch of X-rays should not be brought into the operation theater. Only the relevant X-ray should be displayed, or digitally most often. And disinfection of all the equipment must be done after every single case with hypochlorite or alcohol solutions. And intraoperatively, the surgeon and the whole team must wear the standard PPEs and decrease all the procedures which generate aerosols. So there is a generalized guideline for reducing the usage of cautery, drills, creamers, etc. Now that's really very difficult because most of our surgeries involve doing this, and we cannot really do away with drills and cauteries and reaming as much. But then we'll try to minimize it. We should not use this pulse lavages. We should use hand lavages. Then the dressings should be transparent dressings, as Dr. Trikha has already mentioned. And the closure should be, we should be using staples and not sutures, so that
I think I would like to take a small deviation from here, Dr. Chetan, is because all these guidelines were in the time when emergency surgeries in COVID patients were being done. And now there is a fair amount of clearance that viremia in these patients with COVID lasts for a very short period of time. And that is why blood generated transmission is not the regular mode of transmission. And that's why high pulse lavage and other things can be used safely, including cautery and burr and drill in orthopedic practice. There is a fair amount of evidence there. Let me have Dr. Amita on that. Dr. Amita, now, what is the chance of blood-related transmission in COVID patients? For example, if an orthopedician is doing a surgery and he's wearing a permeable, non-permeable gown already with all the face and other things, can we safely use drills, high-speed lavages, particularly in an asymptomatic patient when there is no fever? Are there chances of virus transmission through blood?
Interesting question. So the thing is that, ideally during the stage of viremia is a time when you will catch infection with the blood splashing. So usually asymptomatic carriers would not ideally be having viremia, but I would say that very little is known about COVID as of now. And therefore, I would insist that every precaution is taken, assuming that the blood is also going to be a source of infection. So though the carrier has a less chance of having viremia, regardless, you have to take full precautions.
Right, very true. Dr. Shushruth, very quick comment on your management inside the OT. You have been doing surgeries. When you do regional anesthesia, what are the general precautions to prevent spread and inside the OT? What are the things that you do intraoperatively in a patient with regional anesthesia, and post-operatively, how do you fumigate these OTs? Is there any special precaution that you take for the sake of all the guys who are having these OTs in nursing homes?
So of course, after wearing this and preferring regional anesthesia, every OT needs to be prepared after every surgery. And so fumigation using of sodium hypochlorite solution and bacillol for surface disinfection, and there is a clear-cut gap of 1 hour between two surgeries. So that's extremely important. We cannot, initial days, previous days, jump into the second surgery immediately. So that has to be, so two surgeries, definite gap, and after every surgery, disinfection of the OT is a must. The rest, Chetan has clearly told, use of positive pressure ventilation, preference to regional, and we are fortunate, we are extremity trauma surgeons, so we can do most of it by either a spinal anesthesia or a upper limb regional block. So we are lucky that way.
Yes, Dr. Ashish, your quick comment on that, please.
Yeah. So one more thing is that when in between the cases, whenever the nurses are moving the trolleys, so you insist that they doff their PPs in the OT complex rather than wearing that and going in the corridors and taking all the equipments elsewhere. The other thing to mention is about the anesthetist wearing the PPs and wearing a lead apron on top of that. So as an orthopedic surgeon, you have to insist that they first wear the lead apron if you are anticipating image intensifier, and then wearing the, because it's a big task trying to convince the anesthetist to change their protocols.
Right. So I think it is easier said than done, Dr. Trika. For all those guys who are listening to this webinar and consider that wearing PPE and doing the same surgery is as simple as like doing a normal surgery, would you please like to highlight the problems of operating wearing a full PPE and then try to tell us what all problems should one anticipate when you are in a full PPE?
But I would say that once everyone has to endure that ordeal to get inside that PPE and do the surgery, if you really want to do that way. The thing is, even a face shield, forget everything, even keeping a face shield which is coming till your chin and then going down and looking into the posterior part of your tibia in the posteromedial or posterolateral approach, it becomes so difficult because you cannot bend your neck to that great an extent. Your mask, the fogging which happens so much. So these things are, forget the PPE or coverall which we have to wear. We are wearing some balaclava sort of a thing, face masks, and that more than 70 GSM PPE surgical gowns and the shoe covers for our surgical procedures. But I'm just talking of that face shield, which we all are going to wear for a long time. Just using that is so difficult. Fogging is a big problem. Sweat along with the lead apron is a huge thing, and your thyroid shield if you're having. So it's a difficult proposition, but
all this compounded by more and more carbon dioxide getting accumulated in your body. And if the surgery lasts 4 hours, I am sure we already have an episode of surgeon fainting, and his ABG really showed that he had a lot of carbon dioxide retention. He was into a surgery for 4 long hours. Dr. Amita, would you agree that all these are problems with PP, sweating, fogging, not able to visualize, and there are a lot of signs available to communicate? You cannot speak out loudly, and there is the accumulation of carbon dioxide in the mask. Any other problems that you would like to highlight here for all of us?
I would just like to say one thing, that a person who does not have underlying pulmonary condition, a person who's not a COPD or abnormal condition, will not honestly have a carbon dioxide which is kind of make him disoriented or something. So the level of carbon dioxide which will go up, you're actually inhaling more carbon dioxide, but the level of PCO2 going up in the blood is about 4 to 6 millimeters more. So at the most, it's basically making you a little lightheaded or a little bit of headache or a little bit of tiredness, but collapsing and all is like rather exaggerating. It would be some other pathology addition.
Right.
So I would like to translate it in another way, Vishal, that the thing is that during the surgery, you are going to be very uncomfortable because of the PPE, because of the N95 mask, etc. So please make sure that whoever is doing the surgery is really an experienced person who goes in fast, operates and comes back. Please don't don't try to teach your juniors. This is not the time to train the RMOs and give them surgeries. Best surgeon operate, do a good job and come out, because the situation is not most comfortable. So if there's a complication, the less experienced person may not take the best decisions.
Yes, there are multiple such questions that will be there, and to which shortage of time may not allow us to answer, regarding how to operate, how to change your surgeries, what are the surgical changes in management of the same indications, and what are the changes in the OT environment that are absolutely mandatory and possible in smaller nursing homes. What are the post-operative cares that we need to undertake? how do we manage these patients, what are the minimal invasive options available for the same indications, and much more apart from the follow-up consultation and telemedicine that we will be discussing in the part 2 of Coexist with COVID. And with this, I would like to call upon Dr. Ram Chadda to please come and summarize today's session, where we spoke about changes in OPD consultation, elective surgery, elective workup to start up, how to gear up our game to come back after the lockdown is over. Dr. Ram Chadda, back to you.
Thank you very much, Vishal. I think we've had a great time, an experience that we would recollect over the next full week, rethink, analyze, and come back. As I load my final set of slides, which I'm going to reduce dramatically, I'd request Dr. Ajit Shinde, President of MOA and Organizing Chairman, to share his final words of wisdom. Dr. Shinde, sir, please.
Sir, unmute yourself. Shinde sir, unmute yourself.
Dr. Shinde, I would request you to say the final words of wisdom, please, sir.
First of all, I would like to thank all the consultants for giving, sharing the knowledge and upgrading our queries. Still, I am like to ask Dr. Chetan whether OT pressure to be keep normal, positive or negative.
Preferably positive, sir. With frequent air changes, minimum 20 air changes per hour. So positive pressure. Which is
I think there is recommendation. I like to come in here is, sir, if the patient is made to wear a 3-ply mask which is nicely fitting and you are using a regional anesthesia, the chances that you will increase aerosol generation in the OT are very less. And in those situations, positive air pressure with those changes Dr. Chetan mentioned is good enough. Of course, with all the PPE that surgeons have to wear, this is something that is going to make your surgery as safe as it possible. And for all the guys who have these nursing homes, please don't get just psyched about negative pressure OTs or having a different kind of infrastructure changes in the OT. No, it is surely not required at this point in time. And there are ways and means of doing safety measures with the protocol that have been discussed, keeping yourself and patient safe by just ensuring that the patient's movement all throughout the while patient is sealed with a mask, his eyes, nose mask and mouth is covered with the mask, and try to use regional anesthesia and minimal invasive surgeries as far as possible. Dr. Shinde, back.
Add something over here.
Yes, please.
Yeah, so basically the thing is that we have to make sure that the air conditions, the air from the air condition of the OT is not recirculated. Right. And it has to be going to the outside. And if the structure is that it can't go to the outside, then a HEPA filter has to be installed. This is very, very important in addition to the
very pertinent. Very pertinent. Thank you, Dr. Amita. Dr. Shinde, your closing comments.
We'll be discussing all that in the next session. Yes, Dr. Shinde, sir.
So, the lot of things are very difficult for the private nursing home to do all the changes. So, whether at peripheral setups, there should be a specialized centers who should do only surgeries, and a certain setup they should conduct only day one procedure and OPDs. What is your suggestions?
Sir, my take on this is that we saw today that the structural changes required are bare minimum. So even the smallest standalone clinic, the only need of the hour is to make SOPs. And mind you, SOPs of any particular hospital cannot be applied to another hospital, provided the infrastructure of every hospital is different. The primary 3 changes that everybody has to follow are the principles of triage. You got to triage patients. You got to screen them outside before you come. Increase social distancing norms, be it in OPD, be it in your consulting chamber, be it in the waiting area, be it in the surgical part. The distancing between the surgeries have to increase. And this is something that we cannot really overemphasize upon. And the third and the most important thing is safety paramount. So safety parameters like Dr. Amita mentioned, N95 masks, gowns, face shields, right from your consulting chamber to all the healthcare workers to the surgeons inside the OT and post-op also. I think these three things do not require any major structural change, but what it requires is the will to do it, and then the will to slow down, like which has been emphasized more often than not, that like Tata said, that this is the time of not evaluating your profits and losses. It is the time to be alive. And if you are alive, that's the biggest profit one can have. And remember the power of human motivation. Arundima Sinha has climbed Mount Everest without having legs at all. Who would have thought 5 years ago that a child of 9 years would have scaled Mount Everest? And that is the power of human motivation, which we always will carry forward if we just slow down and stay alive from here.
So Vishal, even for the peripheral nursing homes, small nursing homes, it's more of a mindset change than a structural change. Only three things, like you have brought out very, very nicely, that it's triage, social distancing, and personal protection and patient's protection. So this is not at all a very difficult structural change that one needs to do even in a smaller setup. But the more difficult thing to do is the change of our mindset. You know, somebody who is used to seeing 100 plus OPD patients has to suddenly bring
I think one carry home from here, I would like to steal away from Dr. Trika's talk. Dr. Trika mentioned we got to really go back to the alcohol shops and learn from them how they are managing those 500 bottles delivery on only phone calls and by coupon system. Dr. Trika, it was a wonderful analog here, and I'm really thankful to you for bringing it out here.
All socioeconomic status can do that.
Exactly. So I think we have to come to a conclusion here for the part one, so that we can move on to part two. And who other than Dr. Ram Chadda to please give us the summary statement for this session here.
Dr. Shinde, anything else you would like to say, or should I summarize?
It is clear that with certain precaution, we can proceed for the surgical management, even some planned surgeries also. At present, we are doing only emergency surgeries, when we can proceed further also with certain precautions.
Sure, sir. Thank you very, very much. As mentioned, this all started with this man telling us that we have to suspect something, and he taught us that it is better to be safe than sorry. Amita has been saying it. She said, a stitch in time saves 9. We have to be very, very careful that there is more than one way of doing the same thing, and we should not get carried away or petrified by reports which may scare us. Please understand, there will be situations which will not be in our favor all the time. New habits have to develop, whether it is wearing the mask, whether it is washing your hands, avoiding spitting, getting the double nasal and oral RT-PCR done, spitting being now penalized, washing your hands as mentioned by Sushruta Babulkar for that 30 seconds properly, a no-touch technique, using all that is on your hand, even like a buddy to use without touching the area, keeping only one phone and that too in a cover, which will be your only contact with the exterior. You need not touch it. Proper social distancing, not just following the rule, but doing it truthfully. Have the N95 mask, use nitrile gloves, do proper sanitization, do cleaning. Please remember, do not get carried away. A lot of us have lost our orthopedic colleagues, and we have to be very, very aware that ignorance is something which is no more a bliss. It is in fact a kiss of death. Please consider everybody around you as an asymptomatic carrier of COVID. As mentioned, so many people to. Please understand that a valved mask is not doing good. It is probably doing harm because you're protecting yourself and you're not protecting anybody else around you. Please remember that you may have to look at a future where you may have to have masks at all occasions, good, bad, and ugly. But do not disrespect the mask. There is a shortage of N95 masks for the healthcare workers. And I would request you to keep it for the healthcare workers and don't misuse it, and use a 3-ply surgical mask for the non-healthcare workers. Please remember, we are fighting it, and we have to always remember that we have to be safe rather than sorry. And if we have to do surgeries with all this on, it's going to be quite an ordeal. 102 years back, you went to jail if you were not wearing a mask. This is where we have to be even today. We have to stay at home and we have to shop by phone, even if it is for liquor or any other commodity. This is how things were 100 years back. And this is how St. Xavier's College looks like today. Please be prepared. We may have to look at a colorful yet as bleak for a future in the immediate future. Please remember that we are now competing with New York in Mumbai. It does not mean that I have to wear all this and sit down in my OPD. No, this is not the way that we have to be in the OPD. Somewhere we have to decide that we have to move from one life to the other and back to the original life that we were all using. We have to understand that we have to educate our patients. Please insist on teleconferencing, teleconsultation if possible, face-to-face consult. Please go step by step and very, very slow. I have started telecommunication or teleconsultation, but believe me, I am doing a telecom of about 15 to 20 minutes and then taking a break for 5 to 10 minutes and then doing the next. In fact, when I do face-to-face, I may even do only 4 consultations in 2 hours, which means I may do half an hour where 20 minutes I consult and 10 minutes I clean the room, unless I have 2 rooms. Please understand, as we have to avoid men, which is the mouth, eyes, and nose. But we have to wash our hands, obey social distancing, mask up, exercise and eat well, and do not unnecessarily travel. 25th, airlines are opening up. What you see to the left of the screen is what the airlines have suggested. We may have to have similar display of signages in our clinics, in our hospitals, on the WhatsApps that we send to our patients, informing them exactly of what all are the do's and the don'ts. Start practicing that today itself. Please remember, it's our duty to educate the society as much as we can. What is wrong with this picture? We've had so much of a discussion about the N95 mask. Respirators do not work if they do not seal your face. Facial hair must not interfere with the seal. Ladies and gentlemen, today many of us are sporting the COVID lockdown beard. Please understand, if you're going to go back to work, you will have to be like Vishal Kundnani, clean shaven, so that your N95 respirator works. What do I mean by this? Well, I share with you 4 of my colleagues, very, very dear friends. In this gentleman, the N95 will be suboptimal. So will it be in this gentleman, so will it be in this gentleman. The ideal situation would be in somebody like this or Vishal Kundnani. So make up your mind. If you're going to be regularly operating and you're going to be using the N95 mask, please be sure that the N95 has a good fit, which is very, very important. And what does that mean? There are only few hairstyles which allow the filtration of the N95 to work. This is available. Please choose your fashion if you are going to be regularly operating. Please understand. And I come to the fag end of my presentation. These are points which have impressed me by a presentation which Atul Gawande made. And I read Simon Sinek very commonly. So I have tried to amalgamate the two. Everything in life is based on products, processes, and purpose. We go as far as COVID is concerned in the same way. The products that need to be concentrated on are sanitizers for the hand wash and the PPE or the masks. The processes which we have to insist on, screening, and proper social distancing along with distance socializing. And finally, the purpose, the mindset which needs to change. The cultural shift has to come. Go slow. This year is going to be slow. Practice a culture of compassion, cooperation, and collaboration. If you know something which can improve healthcare, share it with your colleagues, share it with the nation, share it with the entire world. We are fighting an unknown enemy. The mindset has to be changed from the selfish, which is the valved N95, to the selfless, which is the non-valved N95, to the altruistic, which is the total PPE. Please understand, this is the future. A Canadian journalist, Jonathan Kay, said something very interesting. How do you get transmission from contacts? The commonest place is your home. Next is your workplace. Third is social gatherings. Fourth is mass public transport facilities. And five are bars and restaurants. So beware of these places. What is going to be relatively unsafe in the future? Train and road travel in large groups. Office work where there is face-to-face, boisterous, agitated behavior. So Vishal and I have to be very careful. We can be shouting our lungs out in front of the laptop, but when we are consulting, we have to be like Amita. Few words, softly spoken, and made very, very clear. Less boisterous behavior. Political, religious congregations where there is loud speech and chanting can be unsafe. Socially intimate behavior, public display of affection can be unsafe. Indoor sports like squash, please don't jump into it as an exercise. This may be the most dangerous sport to indulge in. What may be safe then? Well, air travel, because all of us are going to be sitting facing straight. The next seat next to us is going to be empty. There's going to be a flow of air from above going down and exhausted downwards. And it's going to be a shorter duration than the train or the air or the road transport. Office work in front of a computer is going to be relatively safe. Theaters, movie halls with social distancing, listening to an orchestra is going to be safe. But large gatherings where there is going to be a bar or a big show or a music program, well, that's going to be unsafe. Socially formal behavior will be safe. Outdoor sport, if you want to indulge, something like tennis. Unlike squash, where there is less of aerosol generation, where the two people are far apart and it is outdoors. So this is the way to go. Understand, fear is a very dangerous word. I always believe fear to me meant false evidence appearing real. And I always thought faith could overcome fear. Faith was full assurance in the heart. Today, the fear is in a situation where we have to decide between the options and the choices. You may opt and say that I should forget everything and run away, or you may choose to face everything and rise. The decision is yours. Ladies and gentlemen, choose wisely. You can't choose the cards that were given to you in the game, but you can surely choose how to play the game. So play safely, be safe, don't be sorry. Thank you all for a very, 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 very patient hearing. God bless you. Stay safe, stay healthy, change your culture, change your mindset, and go slow. Thank you very much.
Thank you, Dr. Ramchandra. It has been really lucid of you to bring out the absolutely highlighting points of the day. And I think nothing could have summarized better than what you did for all of us by highlighting the point of going slow. With this, I would like to close the session. But before we go home, I think this is the time when I would write with my folded hands, thank the senior most member here who came us all the way from IOA, President Sir Dr. Meena sir. Thank you so much, though you are not here, but please accept our heartfelt gratitude for joining hands with us to spread the word of what we know, the little about COVID here. Dr. Ajit Shinde sir, couldn't have been possible without the blessings and the motivation that you brought across to organize this webinar. I hope the part 2 will also bring in some more intelligent inputs into operative ways to go ahead when we really would be ready to start our elective work. Dr. Karne sir, thank you so much for being around. Dr. Babulkar, it was really wonderful to have insights from Nagpur, and I am sure, and God bless that the city doesn't see any more rise in cases over there. Unfortunately, we are 50 lakh in the world and 1 lakh plus in country here. and unfortunately Bombay being the hotspot, beating New York, which I'm really not proud about. Dr. Chetan, thank you so much for your inputs in there. Ashish, you have been lovely around, and your presence just added to the confidence of bringing the facts around. Dr. Trika from Delhi, you have always been the pillar to post and really motivating all of us. And I think the guidelines that you mentioned for all small nursing homes make more relevance than anyone else, that we will be starting our OPDs with the guidelines that you mentioned. And the brains of the day, I think, Dr. Amita, hats off to you for bearing with us for 3 long hours. And it wouldn't have been possible to learn all the facts that we have all got into our brains. Thank you so much for being with us. And the man behind the show, Ashok, who's the silent killer here, who just keeps smiling without saying a single word. Ashok, thank you so much for organizing this. And I hope in the part 2, we will keep you less engaged with a smaller time frame to come. Thank you everyone for joining hands here. And we really, really appreciate your patient hearing with all of us. Thank you so much.
Thank you.
Thank you.